Anita, I hope I'm still audible and visible properly.
Yes, ma'am. You're still audible and visible, ma'am. It's very clear.
Acha, there is some background noise which you would be getting. Are you getting it now?
No, ma'am. No, ma'am. Your voice is only clear. I'm not getting any background noise.
Perfect. There's a little noisy. I think when I use my AirPods, it will be further reduced.
Sure.
Okay. I hope even if they don't provide me the Wi-Fi connectivity, I can still. I think they'll come with the Wi-Fi thing. We have 5 more minutes to at least go now. Okay. ITC, na? डिस्कनेक्ट हवा अच्छा 80 exactly perfect. Anita, now I'm connected to the Wi-Fi. Are you facing any issues?
No, ma'am. Your video, audio both are clear, ma'am.
Clear and uninterrupted, na?
Uninterrupted, ma'am. It is completely fine.
Okay. I'm keeping myself on mute. 4 more minutes to go, but then we don't have enough participants.
Yeah, ma'am. We are informing them they are like still joining, ma'am. So we'll just wait for like 2 more minutes and then we'll be starting.
Okay. Thank you.
Good afternoon, Romila.
Hello, good afternoon. All well?
All well.
We have few participants. It's almost time, but we are waiting. 1 minute to go.
Yeah.
Anita, let me know when can we start, okay? We must have the panelists and speakers.
Yes, ma'am. I'll be informing you. Just give me a minute. Yeah.
Sonali and Anita.
Yes, sir.
So Vikas has joined. Dr. Vikas Talreja, I could see, but Dr. Amish Vora and MB Chandrakant, they have joined. So has somebody contacted them?
We have already contacted them. Sir is joining, so we have already contacted.
Chandrakant have joined. So just we
Okay.
can start now. So since there are two already, and Dr. Umarang is also there.
Okay. So we'll start the webinar right away, sir.
Yeah, already 5-3.
Yeah. Do it, sir.
A very good evening to all of the participants here. We had wonderful informative sessions yesterday covering various topics of uro-oncology, and we are very much looking forward towards the same for today. So as we start, it will be without, as such, we are 3 minutes late right from the beginning. So without taking much of time, let me introduce you to Dr. Ghanshyam Biswas. He would set the context and give an introduction to today's series. Sir, over to you.
So thank you, Dr. Romila. So now we come to the IAO webinar series Oncology Update 2023 Day 2. So each have a breast followed by lung. So within the next 4 hours, we have panel discussions, we have hot debates, and then some good talks and ASCO updates. And this part of this Day 2, the organizing secretary being Dr. Someswara Panda, and the scientific chairperson being Dr. N.V. Chandrakant. And we'll start the ball rolling with the day 2 quiz by Dr. Someshwar Panda.
Thank you, Ghansam bhai.
Yeah.
So we'll start with the quiz. It is a fastest finger fast. Whoever clicks it fast is the winner. And even all the consultants and all the residents can pitch in. So we'll see whoever clicks the answer fast. And answers will be recorded by the organizers. And they will declare the winners at the end. So first question. Ribociclib in Natalie trial, which one is the correct option? The dose and the duration. So you have to type the answer in your chat box. So the correct answer for it is ribociclib is given 400 milligram. The dose was reduced and the duration was for 3 years. And we move to the question number 2. So this is a very important question from the Indian context. The prevention of hand-foot syndrome by capecitabine. So in ASCO 2023, which therapy has emerged as a new option? You have to give the correct answer, type the correct answer.
Time up for the second question.
Soumya I don't know. So why people are not typing? So they are not getting
Yeah,
it?
exactly. I can't see any answers in the chat box. Anita, is there
There are
any issue?
88 participants. I don't know what is happening.
Yes.
Just a second, sir. I will check from our end, sir. Just give us some moment.
Because there are no answers in the chat box. It is just for the first question, and Dr. Ghanshyam had responded, and that's the only response that is seen. Okay. Should we proceed to the next question?
Just hold on. Let us see.
Okay.
Just a second, ma'am. Just give me a minute.
Yeah, sure.
Yeah, I think the chat box is working.
No, chat is disabled. It's written here.
Oh.
Chat disabled appears. So there are many in the writing wrote that the chat is disabled. Something.
Oh yeah, somebody.
So can we start from the first question now, sir, if it is fine?
Yeah.
Now it's answering.
Yeah.
Now.
Yeah.
ठीक है.
We can go to the third one. We can go to the third
Yeah.
One. Sure, sir.
Third question, please.
So what is the right answer for the second one? No?
So the second question, the right answer is 1% topical diclofenac.
1%.
So we'll go to the third question. So sacituzumab govitecan has been found to be useful in which of the cancer? So metastatic TNBC, metastatic urothelial cancer, or metastatic hormone receptor positive, HER2 negative endocrine resistant pre-treated subset, or is it all of the above? So you have to type the correct answer. So conjugates, they are the future, and you will see them more and more often. So the indications will expand. I think this time all people have answered this question. So we'll move to the next question.
What is the right answer?
So the answer is all of the above.
All of the above. Yes.
Used in
You hinted it in the last few seconds.
And then right now in ASCO 2023, even in pretreated subset, that has shown a good activity when compared to treatment of physician choice. So right now the expansion is for all of the above, but indications FDA labeling is for 1 and 2. We'll move to the fourth question. So what is the correct definition of HER2 low? You have to type your correct answer.
Yes, the answer.
Yeah, so again, HER2 low is again a very important part in the breast cancer management. So the correct answer is 4. That is IHC is 1+, IHC is 2+, but FIS is negative. So this is the correct definition of HER2 low. So next we'll move to the question number 5. So in 2023, what is the ideal way for giving PARP mutant breast cancer? So one has to check which one. Is it the HRD, or is it the HRR, or G-BRCA, or a tumor BRCA? So many people have answered it correctly. The correct answer is germline BRCA. So till now in 2023, we still give the PARP mutant breast cancer based on the germline BRCA. HRD is mainly used for the ovarian cancer, and HRR is for prostate cancer, and germline BRCA is used for the breast cancer. Tumor BRCA is used in ovarian cancer. So thank you, everyone. I think
Thank you.
I'm starting the first and second question, but we picked up in the last 3 questions. Thank you, everyone.
Yeah, thank you, Dr. Soumya. It was a wonderful brain jiggling session, I think involving very much current practices in breast cancer. So quickly, we take upon the first talk of the day, which would be given by Dr. Vikas Talreja, medical oncologist from Kanpur. He would update us about the ASCO breast updates, ASCO updates in breast cancer. So are you there? Anita, do we have Dr. Vikas Talreja?
Sir has already joined them. Just a second, we'll just recheck it.
Yes.
Sir has initially joined, but sir has left maybe due to some network issues, I guess. We are reconnecting with them. So,
so any suggestions? Do we take up the debate or we wait for a couple of minutes? We are already lagging by 3 minutes as of now.
So let us wait for a minute or so.
Yeah, sure.
sir has actually left due to the network issues. Within a minute, sir is joined.
Perfect. Take care.
Ghanshyam, meantime, prizes कहाँ है? I had almost all question papers right in quiz.
तुम्हारा
Hi,
पेटीएम
Dr.
में चले
Romila,
जाएगा।
मेरा prize किधर है?
रोमिला तुम्हारा पेटीएम में भेज देगा अभी।
हाँ, बस फिर ठीक है।
Done. अभी सर announcement होगा. We would announce the winners.
Acha, okay.
Ma'am, Dr. Vikasa has joined, ma'am.
Perfect. Take care.
विकास बोल रहा है मैं लिफ्ट में हूँ
I hope I'm audible right now.
Yes, sir, you are.
Very perfect. I'm very, very sorry for the delay.
It's
I've
okay.
come to Dr. place right now in Delhi, and that's why I believe that's something which is too scary right now. The rain that's in Delhi right now is something which.
So you got stuck in Delhi traffic in rain? Dr. Vikas, you're again not audible. We can't hear you.
Right, please. Next slide. So in early breast cancer, the most anticipated and most awaited trial was the NATALEE trial. As you could see, the immediate randomized open label phase 3 trial at adjuvant ribociclib for an hormone receptor positive breast cancer, where ribociclib was given 400 milligram as an adjuvant therapy, 3 weeks on and 1 week off, as compared to the placebo with the adjuvant hormonal therapy that we usually give. And the primary endpoint was the disease-free survival by the STEEP criteria. The secondary endpoints was the recurrence-free survival and overall survival and the patient-related outcomes, as you could see. Next slide, please. Baseline characteristics were exactly matched with each other. You had stage 2A and 0 exactly matched to each other. Fit performance status. Next slide, please. Next slide, please. So if we look at the risk, the hazard ratio 0.748, meaning a 26% reduced chances of disease-free recurrence, and it became a positive trial with a significant primary endpoint value with a p-value of it, with ribociclib plus NSAI significantly improving the DFS as compared to NSAI alone. And also very important was this
So is it just I who can't hear, or he's not audible to anyone?
I'm sorry. There are some network issues. Am I audible right now?
Yeah, you are.
Perfect. Next slide, please. So 25% disease recurrence, reduced chances, and significant hazard ratio. If we look at the DDFS and the overall survival, even though the overall survival is going towards a non-significant trend, but the DDFS advantage is around 2.2%, and the risk of distance-free disease-free recurrence is around 26%. Next slide, please. If we look at the safety analysis, 19% of the patients had to discontinue with a median discontinuation period of around 4 months from the start of the inceptions. QTC prolongation was significantly increased, and 400 milligram had the lower rates of dose reductions as compared to the Mona Lisa original protocol of 600 milligram. The neutropenia and the ECG were the major determinants for the dose reductions. Next slide, please. So the investigator concluded that yes, it is a significant primary endpoint that has been met with a significant IDFS benefit, DDFS benefit, and a trend towards overall survival benefit. But right now, OS is something which is awaited, and we shouldn't be discussing it. And that's where it has become one of the standard of cares as we need to discuss. Also, the side effects with the discontinuation leading to the QTC prolongation and the the neutropenia. Next slide, please. We already have an adjuvant ribociclib, adjuvant abemaciclib, and is adjuvant ribociclib ready for the prime time? We can see that 25% risk reduction is meaningful. Absolute benefit 3.3% is benefit, but it's still early data with only 20% of patients having completed 3 years of therapies. Unknown if the benefit will persist over the time, will translate into the overall survival, and can be given only with AI. For the 20% of patients who discontinued AI therapies, they are unable to continue on ribociclib with tamoxifen. Is the benefit continuing or not? Don't know. And must weigh the benefit versus the risk 3 years of the therapy. Next slide, please. And we have a monarch E subgroup analysis also where adjuvant abemaciclib was given in high-risk node positive, hormone positive, HER2 early breast cancers. And as we know, it had a 2-year IDFS benefit of hazard ratio of 0.75, 25% reduced risk of recurrence, and also 4-year IDFS benefit of from 79.4 to 85.8, again 34% reduced chances of distant recurrence, and Ki-67 requirement was dropped from the original label. And older patients having more comorbidities, greater toxicities, and are underrepresented in these trials. Next slide, please. So the subgroup was of less than 65 and more than 65. And if we look at the NETLI and the monarch E, probably the grade 3 Ki-67 group will be favoring over the monarch E, and the NETLI will be going for the early N1, T1, N1 lesions. And we also need to look at the BRCA testing in these patients. Next slide, please. A very important subgroup analysis by age, which was done in the monarch E study. Next slide. Was less than 65 and more than 65 age group. As we know that 65 is something which is geriatric right now. Next, please. And that's where we need to see the benefit of it. An absolute benefit of the monarch E by the age, as you could see, was significant. As you can see, less than 65, it was 6.7% benefit. As compared to more than 65, it is 5.2. And the DDFS benefit again was 4.6 versus 6.2, meaning the absolute benefit is differential in terms of the differential age. Next slide, please. And the adverse events, as you could see, the diarrhea and the fatigue were increment with the age. Less than 65, it's 7 grade 3 diarrhea. With more than 65, it's 12%. And similarly, the fatigue, which is nearly quadrupled, as you could see. Next slide, please. And dose adjustment, as you could see, was more with the elderly age group. Nearly 19% of them had to discontinue the therapy without any prior dose reduction, and 38% had to discontinue some form of the therapy during the time. And the 4-year IDFS rate by lowest to highest relative dose intensity was not much incremental difference. Next slide, please. So monarchy also concluded that yes, with age, there is a differential benefit. The younger population tend to benefit more as compared to the elder populations. Higher PS comorbidities were more common in older patients, and dose reductions and treatment discontinuations and side effects were much more higher. Next slide, please. That's why we need to discuss among the various age groups, the performance status, the comorbidities, and the treatment-related adverse events before prescribing the adjuvant form of therapies. Next slide, please. Now comes in early breast cancer, the FERGAIN study, where tailoring therapy based on the early PET response was seen. TCHP 2 cycles with paclitaxel Herceptin 2 cycles, and based on the PET response, whether TCHP 4 was continued, or if those who were not responding from the paclitaxel Herceptin were escalated to the TCHP protocol. So PET shifting to the pathological CR after the same. Next slide, please. So primary endpoint was the pathological CR, and the secondary endpoints was the survivals in all of these. The baseline characteristics were exactly matched. Next slide, please. And you could look at pathological complete response was seen in 79.6% of the patients in group B and received only PH prior to the surgery. Following surgery, pathological complete response was 37.9%, exceeding the null hypothesis. And you could see the pathological complete response was seen in more of HER2, IHC3 positive stage 2 and 3 ER positive and ER negative subgroups. Next slide, please. So PET again is a very important indication as a preliminary response as how soon we can see whether the disease we are responding. And you could look at the 3-year IDFS also, the curves exactly matching each other. The 3-year IDFS rate was 95.4%. And next slide, please. The primary endpoint was achieved. So 3-year outcome again, you could look, the EFS was 98%. Next slide, please. Safety, as you could see, the treatment-related adverse events were in terms of 90, but drug discontinuations and drug grade 3, grade 4 events were less than 25%. There were no deaths related to the study treatment. Next slide. So investigator concluded, yes, the chemo-free the chemo-free regimen, the pertuzumab, trastuzumab therapy is a very effective neoadjuvant therapy, and PET as an interim response can be used as a surrogate marker for the evaluation of an early breast cancers before we get to the pathological complete response as the primary modality. And investigators do conclude that PET-based response adaptive strategy identifies approximately 1 in 3 patients with HER2 early breast cancer who can safely omit chemotherapy and therefore significantly reduce the toxicity. Next slide, please. Now we jump our gears to the advanced breast cancers. Next slide. The sacituzumab govitecan, one of the much more anticipated molecules, the TROP2 inhibitors, FDA approved in TNBCs, urothelial, and the breast cancers right now. Next slide. And as you could see, it is an anti-TROP2 antibody with a high drug antibody conjugate. Next slide. Nearly 7:1 is the therapy, is the drug binding ratio. Sacituzumab govitecan was compared with the chemotherapy in advanced breast cancers, hormone positive, HER2 negative, as compared to the physician choice of treatment, be it capecitabine, vilrobin, gemcitabine, or eribulin. The prior CDK4/6 inhibitors was allowed, taxanes, and more than one endocrine therapy was allowed. Next slide, please. The topic to study, the baseline characteristics were exactly matched between the subgroups. And next slide.
So we are left with just 2 minutes.
Perfect. So you could see time to time, there is a separation of curves, 35% reduced chances of progression. Next slide. If look, 21% reduced chances of deaths with 2-year significant difference between the two curves. Next slide. And depending upon the TROP2 expression level, the higher the expression by the H score, the higher is the incremental benefit out of it. Next slide. And also by the HER2 status, also the higher the score, the larger and the incremental benefit it is there. Next slide. Better responses, durable responses, duration of response nearly double from 5 months to 8 months. Next slide. Treatment-related adverse events, anything with the chemotherapy, neutropenia, and fatigue. Next slides. So again, sacituzumab govitecan again has an OS advantage, PFS advantage, and for those who have an ET resistant, hormone positive, HER2 negative, metastatic breast cancers, post CDK4/6 inhibitors serves as a very important options to discuss for for our patients. Next slide. Patritumab deruxtecan, we can skip that because that's not available in India. Again, next slide, 3 slides, we can move forward. We can jump to the conclusion. Yeah, so again, this also is based on broad range of action, HER3 expression, not available in India, but do have an important phase 2 data and potentially practice changing in near future. Next slide. So as we see, we discussed more in terms of the adjuvant therapies, tailoring of the adjuvant therapies in metastatic breast cancers, omitting chemotherapies in HER2 positive breast cancers, and in advanced breast cancer.
So
CU molecule discussed.
time is
Thank you for your
almost up.
patient listening. That's it.
Is it all done, sir?
All
Dr.
well,
Vikas?
all done. Yeah.
Oh, okay. Thank you for making it up despite rains in your region. And thanks for this facts-rich session. We now quickly move towards one of the most interesting sessions that we can have, that is debate. So the debate will be all about adjuvant CDK4/6 inhibitors in breast cancer. Dr. M.V. Chandrakant, medical oncologist from Kolkata, will be speaking in favor of it. And Dr. Amish Vora from New Delhi will be speaking against the thing. We have Dr. Prabhaj N. Mahapatra, medical oncologist from Kolkata, who would give his expert opinion. The speakers will get 6 minutes each for their topic, 1 minute each for rebuttal and re-rebuttal. And finally, we'll have our expert opinion at the end that will again be within 1 minute. So can I please call upon Dr. M.V. Chandrakant to start?
Visible?
Yeah.
Audible?
Yeah.
Okay. So, well, good evening, all of you. It is my honor to present in front of 150 people, which I hardly see in any of the physical conferences. So today I'll be speaking, we should give adjuvant CDK4/6 inhibitor in HR positive, HER2 negative breast cancer with respect to Mahapatra sir, Ghanshyam sir, and Amish Vora sir. So, well, these are my disclosures. I have made these slides, and these slides are not given by pharma, and no pharma gives me anything for this talk. So that means I am unbiased. Okay, and whatever I'm speaking is to the best of my knowledge, and I'm not here to hurt any authors, players, or political parties. So this is my situation right now. On the left, you can see Novartis and Lilly, very tensed and how well I win or not. And the right hand side, there is Chandrapal, but I am Chandrakant, and you can see the bouncer from Bretley, and the Bretley is here, Amish Vora sir. So
oh my God.
I am right now. So this is my situation. And finally, what are we saying? That's what Vikas said just a minute before. With adjuvant CDK4, IDFS is there, DRFS is there, OS is awaited. That's all the matter cruxes. These are the eligibility criteria for Monarch E. 4 nodes, 1 to 3 with tumor size are great. Similarly, Natalie has a greater inclusion, even a T2N0 with a higher grade or a high Ki67 or a higher genomic risk. So these are the boring data, that for which we are not here. We want some entertainment. So 6.9% is the absolute difference in IDFS at 4 years, which is phenomenal. And 3.3% in Natalie. Again, that's phenomenal. You cannot ignore these numbers. And the hazard ratio is also impressive. Distant relapse-free survival, 6.1%. Look at the numbers. I know it's boring. The numbers cannot be remembered, but still I'm just have to say this data. So 3-year DDFS, just now Vikas was saying was 2.2%. So these are the numbers and they cannot be ignored. I think Vora sir also will not be able to ignore it. So in my Aapki Adalat, what are the questions which I'm supposed to answer? I am supposed to say that whether the trial is overpowered or not, whether IDFS is a good endpoint or not, crossover, informative, sensitive. I'll just go through whatever best I can defend, So if I conduct a large trial, you say you are overpowering. If I conduct a small trial, you say you are underpowering, So it's like a son, father, and a donkey. Whether you carry the donkey, whether you sit on the donkey, people are there to speak. So do not give much weightage for that. Look at the number of patients in adjuvant trials, 12,000 in Atlas and 5,000 in Hera. Attack has 6,000 odd patients. So all adjuvant trials have huge numbers, 8,000 in Big 198. So all the trials, have large number of patients, not just Monarchy or Natalie that has 5,000 odd patients. So what is the intensity of breast cancer? 20 lakh women get diagnosed with breast cancer every year. Just look at the number. 7 lakh women die of breast cancer. So we are speaking of one of the topmost killer in cancers, and any small difference, any small difference makes big differences. So the saying is, the criticism is large number of patients you have recruited to show small differences. This is not true. Even small differences in a disease like breast cancer will benefit large number of patients, because breast cancer is so common. Even a small difference in breast cancer brings a difference in large number of patients. So this first thing is gone. So this is the picture of Auschwitz concentration camp in Germany in 1942. So you can see the home, people are entering into the concentration camp and there is no exit door. You can only enter. If you have to exit, you have to exit through a chimney. You're burnt alive after the gas is given. So that is the very sad scene that we actually see. Lakhs of people were burnt alive. And why these people are happy? These people are not happy because they are free. They're happy because the home into which they're entering does not have a chimney. That means they are not going to die, and maybe tomorrow they're going to die. So even one day, if you can live, it's chilling cold, still they're happy because I'm not going to die today. So if you ask a person who is dying, so he says, wow, how much one day means to him. So even one day of survival counts. Even 1% living counts. So the all criticism is IDFS using. So IDFS is not a good endpoint. Overall survival is an endpoint, but we never saw, the multiple adjuvant trials, the steep criteria said it is not practical to wait for overall survival. Overall survival will take 10, 15 years to come. Until then, what about these patients? The active treatment will not be offered to them. Therefore, the steep has said IDFS is the ideal endpoint for adjuvant clinical trials. Therefore, that is the way to go. So, we heard of this
1 minute for
NRC.
you.
Where is it? 1 minute? 1 minute? Okay. Then I want one more minute extra. Okay. So I think these are the things that are required, but so there is no, so the whole problem is that you are saying that you're not giving CDK4 at progression, but that is not so. So, why don't you ask whether you have given crossover or you've given active drug in all other subset, like adjuvant, nivo-ipi, TRAS2, TDM1, olaparib, imatinib. In all these trials, you never asked whether you are crossing over, but only in this monarchy trial, you're asking about giving active drug. So do you believe that HR positive breast cancer is deadly? Yes, it is deadly, because here is the question of whether you're curing or whether you're palliating. IDFS and DRFS are relevant endpoints. Endocrine resistance is an issue, and there's something called carryover effect. You should give the best treatment in the first line. You have to have the best
Time up.
batsman. And 1 minute.
Yeah.
So there is high censoring in ABIMA. That is what is said after the adjustment of sensitivity analysis. The curves do not show overall survival. And I think I will finish with this one. This is the worst case analysis that is done. And this is the analysis of a worst case analysis. Pakistan is 250 for 6 and India is 240 for 3 and 49 overs. And India need 11 runs and 6 balls with 7 wickets in hand. And the worst case analysis says that India would lose 6 wickets and 6 balls. So this is the very pessimistic way of looking at worst case analysis. And this is to say that MCBS A is for Abhima Cyclip. And he's the author, who is criticizing the trial. And he has criticized not only this trial, he's criticized renal cancer, mesothelioma, everywhere. He says it doesn't work. And this is our prime minister saying how to handle these guys. And my conclusions are adjuvant CDK4/6 inhibitor, improve DFS, IDFS, DRFS, OS is immature. IDFS and DRFS are relevant and independent endpoints, not just surrogate of OS. Both NCC and ESMO acknowledge it. Even one day of life without disease matters. Adjuvant CDK4 inhibitor should be offered to all eligible patients. Thank you.
Very well presented, Dr. Chandrakant. I don't know how will Dr. Vora take it up. Sir, all the best to you. So are you there with us? He was there with us. So, yeah. We have a slide on the screen.
Yes, I am also there.
All the best.
Now, how do I make this as a full this thing? Just 1 minute, huh?
Sure.
1 minute. So चंद्रकांत को देखते ही ना डर लगता है मुझे हमेशा. Okay. Promila, both are clear?
Yeah, absolutely.
Okay, perfect. So my time starts now. Thank you,
Yes.
Dr. Chandrakant, for setting the stage. 6 minutes I have. Actually,
Yes.
Chandrakant, awesome and amazing cartoons and films and clips. And I always wonder, yaar, agar itna acha dikhne se science bhi sahi ho jata, then we would not be debating. Yes, those were amazing, but I don't think they were relevant today. And I'll tell you why. First of all the examples what you have given, Dr. Chandrakant, are similar examples. They are not the justification for the wrongdoing what has been done so far. Because Nivo EP ने ये नहीं किया इसलिए monarchy में चलता है, it is not the right way to look at it. Why was it not done and what was the impact on that? That is what something which we need to see. And that's the reason my belief today is that there is still not enough mature data, and we will do injustice to our patients and science if we offer adjuvant CDK inhibitors in adjuvant setting in patients with EBC. Now, question is, do I have the proof? Before going on the adjuvant setting, I want to go through this particular slide. This was presented in ASCO 2023, SONIA trial. It was not given the great platform, but it has been hailed. First line CDK4/6 inhibitor in metastatic setting or second line CDK4/6 metastatic setting. We have been discussing this. Then Dr. Sudeep Gupta has been telling me since long that he always believed that whether you give CDK4/6 inhibitor in the first line or in the second line, the overall survival does not matter. And this is a randomized trial from Netherlands. And what they have said very clearly, and I'm still talking of metastatic setting, that not only the survival is not different, but you are unnecessarily giving CDK4/6 inhibitor for 16.5 more months, 42% increase in grade 3-4 toxicity, and $2 lakh extra in US. I don't want to change it into Indian rupees because we have multiple things. Let's talk today, where do we stand and today's topic. I just downloaded this NCCN guidelines and I don't see anywhere abemaciclib or ribociclib or palbociclib. All I see is a footnote. You may consider it is still not the standard of care which is there. Let's talk about the proof. 4 trials we have. All the 3 drugs have been tried. The 2 trials are negative and 2 trials are positive in terms of IDFS as the primary endpoint. Not a single trial has reported OS. And why is OS important? Let's go back to the natural history of early breast cancer. Initially, we said 5 years tamoxifen, then we added ovarian function, and then we said 5 years or 10 years. And if you see in Lancet 2011, EBC TCG have concluded that interpretation in breast cancer, even 10 years is not enough. What are we talking of 2 years and 4 years? And this is what I have shown. The blue line dekho ya orange line dekho. The natural history of these patients is such that even with just tamoxifen, 95% patients are alive at the end of 5 years. So these are not disappointing results. And same is true when you give chemotherapy. Look at the placebo arm. All I wanted to show in all these trials that the placebo arm itself shows that even if you don't add CDK4/6 inhibitors, 94% patients and above are going to be 5 years and above. Now you want to look at IDFS. IDFS patients of HR positive keep relapsing. In fact, 50% of relapses are beyond 5 years. What are you looking at 2 years and 4 years? My God. Let's look at this PALAS trial. And we all know that it failed in primary endpoint and overall survival. But here, if you see, endocrine therapy alone probably was doing better. Probably was doing better. This is a late-breaking abstract in ASCO 2023, and Dr. Vikas Talreja presented this, and he concluded also. Look at this Natalie trial. Oh, positive, hazard ratio 0.748, and Chandrakant said, even Dr. Vora cannot ignore. Of course, I'm going to ignore these data. Look at the number at risk. 11% maturity at 3 years, and they're talking of hazard ratio being positive. What are they talking? Look at that, the self-proclaimed. This is not I am saying, this is the ASCO discussion saying, Novartis AG self-proclaimed hit on Natalie trial. Not that the trial was successful, the hazard ratio of 0.748, but if you see, it was shown that it will be 0.65 to 0.7. That would be the expectation. So 0.75 is falling short of that. Subgroup analysis later was one done, again was presented with Vikas 0.63 in node negative. But look at interval crossed 1. So this does not imply any numerical benefit. So far, palbociclib has failed. Ribociclib is too early to see anything, any meaningful data. Let us come to abemaciclib. March 03, 2023, FDA approved abemaciclib. Okay, it removed Ki67. But even today, NCCN has not included in that top. It is just in the footnote. Why? And this is what Dr. Chandrakant has alluded, but you cannot ignore. Look at the reviewed article in Lancet Oncology, June 2023. The title says, review of monarchy, 1 minute more, Promila, not more than that, suggests no evidence to support use of adjuvant abemaciclib in women with breast cancer. They have said, large sample size, small differences, unblinded study, open to bias. Primary endpoint, not a valid surrogate for overall survival. And overall survival, they did not allow, and I will come to that in the control trial should receive ribociclib on progression. This slide you cannot ignore. Without adjustment, the overall survival and the IDFS goes in favor of abemaciclib, but with sensor adjustment, it looks like probably abemaciclib is detrimental. I hope it is not. And look at this, what are we doing? 49% of abemaciclib patient as compared to 16% in control arm have grade 3 or worse adverse events. 2 of 15 deaths in abemaciclib is because of abemaciclib, and in adjuvant setting where the natural history 94% and above patients are going to be alive, you are causing this much of problem. And they are criticized. Monarch 3 trial, they wanted everyone to receive abemaciclib, but in adjuvant setting, they don't want to receive on relapse. So it is biased in favor of adjuvant setting. And there are only 2 ways we can improve outcome of our patients. One, either by improving their duration, that is overall survival, or quality. Either of them are not reported or in favor of CDK. So the final conclusion was adjuvant abemaciclib has shown no improvement in overall survival with median 42 months of follow-up. It is toxic. It is expensive. Cost-effective ratio of infinity given 0 life years gained. What are we doing, Chandrakant? So finally, my final slide is palbociclib has negative trial, ribociclib has immature data, abemaciclib has FDA approval, but I am sorry to say, no OS data, faulty design, sensor adjustment. Why should we be giving? No, we should not give CDK4/6 today, 8th of July, 2023. Thank you so much.
Thank you, Dr. Ramesh. It was a good fight. Now I give 1 minute to Dr. Chandrakant for rebuttal. Your time starts now.
It's a wonderful presentation. I have only one thing to say. If I am a cancer patient, I am cured of cancer, I would like the cancer not to come back, the cancer-free years matters to me. You are saying cancer जब आएगा तब दवाई देंगे. ऐसे कैसे होगा सर? मुझे कैंसर वापस नहीं आना है. बिना कैंसर से जीना मतलब बनता है सर. Even for me, IDFS and DRFS are important endpoints. Cancer-free life is a good endpoint. कैंसर हो के मर के जीने से क्या मतलब है सर? दवाई खा के बिना कैंसर में जीना ही जीवन है. This is my saying, sir.
Sir, now Dr. Vora.
For lung cancer, I agree with you. Adura trial, agree with you. Chandrakant, यहाँ पे without abemaciclib, 94% कैंसर के बगैर ही जीने वाले हैं. ऐसा नहीं है कि बाकी 30% कैंसर के साथ जीने वाले और 70%. You are looking at such a minute difference, and that also with faulty design.
Sir, it is minute.
And that's why I said look at the Sonia trial. See, मेरा turn है तब तुम बीच में नहीं बोल सकते.
Sir, Sonia metastatic है. Sir, Sonia metastatic.
Go ahead.
So can we now have the expert opinion from Dr. Mahapatra, please?
Thank you. Actually, both these speakers are nice. Actually, what I understand, we started with tamoxifen in hormone-positive breast cancer. The patient, what we understand is hormone-positive breast cancer, the recurrence, there are recurrence actually. If you see the 5 years, 5 years is not enough because we see a lot of patients with late recurrence actually. the primary endpoint in the breast cancer trials, actually, the IDFS or distant disease-free survival, getting a OS survival is very late. You will see the OS actually in very late, actually, especially in hormone positive, where we just recently got 2 patients after 10 years, they relapsed and they're hormone positive, actually. Anything we started with tamoxifen, we went into AI, or we combined with GnRH analog with exemestane, only to get a benefit of 3%, maybe 4% or 5%. But these drugs are expensive, actually. It's not for everybody. But I think we must discuss with our patient that this is the benefit you will be getting, this is the cost, and these are the side effects. They may accept it or not accept it, but we don't know. When the Natalie trial is very immature, actually. It is a 20% of the patient has completed only. I've listened that Natalie trial in ASCO also. That 20% of the patient has completed, 80% has not completed the treatment, actually. And we don't know. They are actually Natalie. Because only thing is actually they are using a low dose of ribociclib, which is less toxic, and 3 years because of the cell cycle arrest. And we don't know that may, what will in OS, what will that imply in the late, actually. That OS will be getting late, actually. Abemaciclib, I was of the part of the trial, actually. We have around 10 patients, 3 in without abemaciclib and 7 with abemaciclib in adjuvant. And 1 in each group has relapsed, actually. That patient has relapsed. So if you see the abemaciclib trial monarchy, actually, if you see the 2-year, 1 year, 2 year, 3 year data, now 4 year data also actually come, you can see that it is maintained, actually, slightly better with IDFS and the distant disease-free survival. But it's actually, there is a criticism of the trial, and there is counter criticism of the trial, actually, is there, actually. That's not for everybody, but we must have a mature data, OS data. We see how this hormone positive disease actually are behaving late, because they relapse late. If you see the 5-year data, you will see the 5-year hormone therapy is okay also. If you see the late, because there is a lot of late relapses, actually. Because we need in oncology, everything we need little bit better, little bit better, little bit better. If something is little bit better, if the cost and side effect are, patient is, it's like to explaining the patient. If the patient tells, okay, we want that, we accept the side effect, we want to take that risk of the side effect, we have the cost, then that's they can be taken. But it's, we cannot tell, it is like that. The more the data get mature, more the will get the real evidence that is actually. But till now, I agree with both of them, actually. Both of them are correct in their way, actually. But we need to see mature data, actually, to tell. But it's there. It will be there. The adjuvant in breast cancer will be there. It is either BRCA positive olaparib or BRCA negative, this hormone positive, this abemaciclib or ribociclib.
Very well concluded, sir. I think it was well supported by both, for both, in support of both. So before we proceed towards our next talk, here we would like to announce the quiz winners. Amish Vora sir is very excited to hear his name. For the first question, it is Dr. Ghanshyam Biswas. So it is by default, because at that time none of them had the chats active. For the second question, it's Dr. Chandrakant. The third question, Miss Shubhangini. For the fourth one, sir, Dr. Amish Vora. And the fifth one, Hema Shruti. So a loud round of applause for each of the winners. And we quickly take upon our next talk. A very important topic, neoadjuvant and adjuvant therapy in triple negative breast cancer, the recent advances. It will be taken up by Dr. Uma Dhangi, medical oncologist, Navi Mumbai. Dr. Uma, are we there?
Yeah, I'm here.
Yeah, perfect.
Should I start? Can I share? You shared my slides already. Is it okay? I thought I was going to share it. Anyway, all right. So thank you, Dr. Biswas, and thank you, organizers, for inviting me. I think that it feels good to not travel, but next time maybe we'll do a physical meeting. So I'm going to talk about neoadjuvant and adjuvant chemotherapy in triple negative breast cancer, the recent advances. Next slide. So triple negative breast cancer obviously refers to the absence of these receptors ER/PR and HER2 on the tumor. And it is an aggressive tumor with a higher risk of relapse, with including visceral involvement, including liver and brain. Now, chemotherapy has remained the mainstay of treatment for this type of breast cancer. And most patients with early stage disease will require either adjuvant or neoadjuvant therapy, in addition to the surgery with or without radiotherapy. Now, recently, there has been a lot of interest. We are debating about CDK4/6 in hormone positive. So there are a lot of new interest happening even in triple negative. They're looking at PARP inhibitors, immunotherapy, and some of these have actually shown some promising results. And the new interest is also about changing treatment based on the response to neoadjuvant chemotherapy. Next. So looking at impact of chemotherapy on the outcome. So this is a paper which looked at 3 trials of more than 6,000 women with node positive breast cancer. And they tried to analyze the impact of chemotherapy based on the estrogen receptor status. They looked at low dose versus high dose. They looked at, one trial looked at paclitaxel versus no paclitaxel. Another looked at a 2-weekly versus a 3-weekly regimen. And if you look at the difference in disease-free as well as overall survival, the impact was most seen in patients who had a ER negative tumor. So definitely these triple negative tumors are more chemosensitive than their other than the hormone receptor positive tumors. Next slide, please. So again, coming to what kind of chemotherapy. So if it started with CMF and a lot of other drugs. So this meta-analysis looked at more than 1 lakh women in 123 trials, and they tried to analyze the differences in different polychemotherapy regimens. And what the conclusion was of this EBCTCG analysis was that anthracyclines, yes, they do benefit compared to other chemotherapy, as well as taxanes when added to anthracyclines did impact the breast cancer mortality in these patients. Next. So when do you give it? Should we give it in neoadjuvant? Should we give it in adjuvant? Do we operate first? So when you look at the long-term outcomes, now this is a very old study. So patients were recruited right from 1983 till 2010. What they found was although there was no difference in the DFS or overall survival, the breast conserving rates were much higher in patients who received neoadjuvant chemotherapy, obviously. But they found that the local recurrence rates are actually higher in neoadjuvant setting. This could have been because of various reasons. The older, the old time RT surgery may have been different, but we know now that, neoadjuvant, or whether you breast conserve or not, the local recurrence rates are not very different. Next. So adjuvant therapy recommended for all tumors more than 1 centimeters and node positive disease, irrespective of tumor size. Neoadjuvant is recommended for stage 2 and stage 3 triple negative breast cancer. So what are the goals of neoadjuvant therapy? So they're multifold. One is obviously most important, improvement in overall survival. We always talk about that. In the current era, obviously we are seeing younger and younger women with breast cancer. So possibility of breast conservation is always important. And with the newer treatments available, risk adapted therapy. So those patients who do not respond as well to neoadjuvant chemotherapy, who have a residual disease, can we modify the treatment based on the response and alter their outcomes in any way. Next. So how do we add on the standard therapy? We're looking at chemotherapy. There is capecitabine and platinums. We have PARP inhibitors in germline BRCA mutation positive tumors. Immunotherapy has been added and studied, in fact, approved recently. And we have a targeted drug as well. Next. So this is the CREATEC study. It's a very, everybody knows this study, so I won't go too much into details. Basically, patients who had no pathological CR and node positive tumors after neoadjuvant chemotherapy and surgery with good PS were randomized to either receive capecitabine or no further therapy. And if they were hormone receptor positive, because both were included, if they were hormone receptor positive, then hormone therapy was allowed in the adjuvant setting. The primary endpoint was a disease-free survival. Secondary endpoints included overall survival, time from first day of preoperative chemotherapy to recurrence or death, safety, and cost effectiveness. Next slide. So when we look at the 5-year efficacy, there was definitely an improvement in 5-year DFS as well as overall survival in these HER2-negative breast cancer patients who had residual disease. If you look at the 5-year overall survival, it was 89% with capecitabine compared to just 84% with no capecitabine. And this impact was actually much more evident in patients who had a triple-negative breast cancer than the hormone positive. Next. Coming to role of platinums. So this is our very own study from Tata Memorial published by Dr. Gupta sir, where they looked at adding platinum or carboplatin to sequential taxane anthracycline neoadjuvant chemotherapy. So they had about 720 patients who were randomized to receive the standard therapy, which was paclitaxel. Here it was given at 100 milligram per meter square weekly for 8 weeks. This was followed by either the standard AC or EC regimen every 3 weeks for 4 cycles. In the experimental arm, they additionally added carboplatin, again given weekly as AUC2 to paclitaxel arm. If you see, which is expected, the PCR rates were higher, 55% versus 41%. And the 5-year DFS was 64 versus 70%, which was not statistically significant, but the 5-year OS they have published as 66.7 versus 74%, which was significant. What they did do a subgroup analysis, and they looked at the outcomes of patients who were less than 50 years of age. And here they found that the advantage in the DFS and OS was much more seen in the young premenopausal women. Also, obviously, the toxicity was much higher in the carboplatin arm. Next. So this is another meta-analysis which included 8 trials, again published by our colleagues from AIMS, looked at more than 2,000 patients. They looked at 8 trials who had used carboplatin in the neoadjuvant or adjuvant setting. The PCR rates were higher as expected. Toxicity was again higher as expected with anemia and thrombocytopenia. But here they found that both the DFS as well as overall survival were improved with addition of platinums. Next. This was recently published as a letter to editor, where they looked again at a systematic meta-analysis where platinum was used as neoadjuvant chemotherapy. Here they looked at the 6 trials, including JAPAR 6-TO, OCTO, Brightness, etc. And what they found was the event-free survival was definitely better with the addition of platinum, but it did not impact the overall survival. Next. So coming to BRCA and PARP. With the advent of PARP inhibition, I think BRCA has become more and more interesting. Only 5% of breast cancers usually have BRCA mutations, but this number is significantly higher in triple-negative patients, about 10 to 20%. And this has become more important because now we have a target and we have a treatment for that particular target. Next, please. And who should be tested? Like I said, now that we have a target, we should be testing most patients who are all triple-negative patients who are less than 60, and those who have multiple, or those who have very strong family history. And this also helps to decide whether to use adjuvant olaparib or to use olaparib in the metastatic setting. Next. So this was the trial, Olympia, which where both men and women with germline BRCA mutated HER2-negative breast cancer, high-risk group. So those who had received prior neoadjuvant should have residual tumor, and those who had received only adjuvant chemotherapy had needed to have at least a T2 or a N+ disease in the TNBC subgroup. They also had a hormone positive subgroup where the risk stratification was slightly different. Patients were randomized to either receive olaparib 300 milligram twice a day for 1 year or placebo. Again, the primary endpoint here was invasive disease-free survival, and secondary endpoints distant DFS, OS, and safety. Next. So if you look at it, most commonly, the mutation seen was BRCA1, almost 71% well-balanced in both arms. Most patients were TNBC or triple-negative, 81% and 82.8%. Next. If you look at the invasive disease-free survival, it was updated in 2022. Definitely, it was much better. In the 4-year IDFS was 82% versus 75%, with absolute difference of 7.3, hazard ratio of 0.63. So definitely, it improved the IDFS in patients who had germline BRCA mutation. Next. Look at the subgroup. TNBC did a little better than the hormone receptor positive HER2 negative, probably because we also give hormone therapy for these patients. Next. Even the overall survival, if you see, not absolute difference is 3.4%, 89 versus 86%. Again, statistically significant. Next. Again, with respect to hormone status, we see that the TNBC patients did much better compared to the hormone receptor positive patients in this. So this olaparib did benefit triple negative patients with germline BRCA mutations in terms of overall survival, as well as in the IDFS when given in the adjuvant setting. Next. Safety. So PARP inhibitors, we are always worried about second cancers. We're always worried about MDS, AML, but there was not much a difference in terms of the side effects of pneumonitis, AML, MDS, or new primary malignancy. But more patients in the olaparib arm did discontinue treatment due to toxicity. Next. Coming to our favorite immunotherapy. So these are the 4 trials which have looked at addition of different immunotherapy drugs to chemotherapy. The Jepar Neotrip, Tripa PD-L1, Keynote 522, and the Impassion 031. So different drugs, Durva, Atezo, Pembro, all have been looked at. And the endpoints of these trials, the primary endpoints of these trials were mainly PCR, which was at that time used as a surrogate marker. Both the Jepar and the Neotripal did not have much difference in the PCR rates, but in the Keynote as well as in the Impassion, there was definitely improvement in the PCR rates when immunotherapy was added to chemotherapy backbone. Next. So looking at Jepar, this was patients with triple negative breast cancer randomized to receive either Durva or placebo. Here Durva was initially given as a 0.75 gram IV and then added with chemotherapy at 1.5 gram. There was no adjuvant immunotherapy in this in this trial, only given in the neoadjuvant setting. It had a lower risk population with almost a third of patients having stage 1 disease. Next. So although if you look at the PCR rates being low, not low, but being comparable, if you look at the overall survival, it was much better when Durva was added compared to only placebo. This is a small trial of 174 patients. I don't think we are going to jump to this. It's a phase 2 trial, but it is interesting to note that in spite of having similar PCRs, the overall survival is better in the Durva arm. Next.
2 more minutes to go, ma'am.
Sorry?
2 more minutes to go. Sorry to interrupt.
Yeah. No, that's okay. I'm finishing in 2 minutes. So Keynote 522, this is the study which led to the approval of pembrolizumab in the neoadjuvant setting by the FDA. Patients with, again, node positive or T2 plus triple negative breast cancer randomized to receive pembro with paclitaxel or anthracycline cyclophosphamide. And here post-surgery patients were given pembrolizumab 200 milligram 3 weekly. Primary endpoints were PCR. Secondary endpoints, like I said, was EFS. Next slide. So PCR definitely better with pembro. And interestingly here, we talk so much about PD-L1. It didn't matter whether patients were PD-L1 positive or negative. The CR was better irrespective of the PD-L1 status. Next. If you look at the EFS, definitely better, median follow-up of 39.1 months, hazard ratio of 0.63, 84% versus 76.8%. So definitely significant improvement in event-free survival at the interim analysis. Next. But the big but is the side effects. So there were increased number of immune-related adverse events in this study. If you see the grade 3 to 5, it was 14.9 versus 2.1%, which is quite significant. And a drug was discontinued because of side effect in almost 10.9%. There were even a few deaths due to toxicity in these in the pembro arm. So definitely the toxicity is there, and in adjuvant setting you really don't want too much toxicity as well. Next. Impassion 031. This was looking at atezolizumab plus nab-pacli versus placebo in, again, TNBC. Primary endpoint was PCR. Next. Here too, the PCR rates were higher, irrespective of the PD-L1 positivity or negativity. And I think in the recent, in May, I think they came up with the EFS data, which has not shown much difference compare whether atezo was given or not. Next slide.
Ma'am, time up, please.
Yeah, just 2 slides. So
Sure.
what is the future? Immunotherapy. We are looking at different trials. Pembro with doxy without anthracyclines or no, whether to continue Pembro or to stop Pembro in patients who have achieved PCR, PARP inhibitors, neoadjuvant or monotherapy or combined with Durva. And you have sacituzumab also coming up in combination with Pembro. Last slide. So to summarize, sequential anthracycline and taxanes remain the backbone of chemotherapy in triple-negative breast cancer. Sequencing and dose intensity is important. Role of platinum, definite improvement in PCR and EFS, maybe OS in some subset, but toxicity is definitely a major concern. Again, immunotherapy, similar, approved with neoadjuvant chemotherapy, but a lot of questions still to be answered. Is adjuvant really needed if PCR is achieved? How do we select the patients? And what chemotherapy backbone to use, not to mention the toxicity that we have seen. PARP inhibitors definitely have improved outcomes in germline BRCA mutation positive patients. So I think they're probably we are more comfortable using. That's all. I think that's my last slide. Next. Yeah, thank you so much for listening.
Thank you, ma'am. That was highly informative with relevant informations. Now we take up our next talk.
Ma'am, sorry to interrupt. Ma'am, Dr. David Arya has joined, ma'am. So we can go as per the agenda.
Perfect. Good evening, sir. Good evening, Dr. Devrat. So I just hand it over to you on the topic Onco-Precise Risk Predictor, Prosigna. It's sponsored by Lilac. Please take it up, sir. Thank you.
Okay, let me just share my slides. Can I request the organizers to display the slides for me? Is that possible?
Yes, sir. We will do it, sir. Just a second, we are sharing.
Yeah, at the outset, thank you very much, all the organizers, for this invitation. Obviously, this is a talk on Onco-Precise Risk Predictor. So I'm going to be talking on this very specific and very useful test and the utilities that we have. I'd like to thank Lilac at the outset for the slides and for the data set. Okay, next slide, please. So we all know breast cancer is an increasing issue in our country. It's already one of the most common cancers across sexes, the most common cancer in women. Nearly 150 to 160,000 new breast cancer cases being diagnosed every year. And while we've lamented about the fact that most of our women present with the more advanced stage 3 and stage 4 disease, we actually deep dive into the data. We actually realize that nearly 65,000 women in India present with an early breast cancer as well. And I think that's a substantial number. And that's an increasing problem. And I understand that will vary across practices, across settings where individuals are treating patients. And I, in my own practice, very commonly see patients with a T1B, T1C tumor, and much more than the more advanced settings. Now, we know that these are highly curable, particularly if they are ER and PR positive and HER2 negative, particularly if they are node negative. But you always question what would be the role of adjuvant treatment, the role of adjuvant chemotherapy in this setting. And in a lot of cases, you would want to give, even though when you look at data, only about 15 and 100 on an average.
Is it hung just for me or for everyone?
Sir, you're not audible, sir.
Dr. Devrat, you're not audible. I think your screen is frozen. Anita, please check with him.
Ma'am, sir is facing network issues, I guess. We are trying to connect with him, ma'am.
Okay, perfect. So Delhi NCR indeed is struggling with network today. So welcome back. So please carry on.
It's not the network, it's actually the electricity connection, and we are having a lot of rainfall today. So I think, am I audible?
Yes, sir, you are.
Hello.
Yes,
Yeah.
sir, you are. Yeah.
I think the power connection doesn't like the fact that I still talk about relapse in early breast cancer. So anyway, next slide.
Again got frozen.
Again frozen.
There's issue of no, so rains,
Yeah.
electricity,
Rain, electricity, internet, everything.
Yeah. So I'll start with a case, and you'd realize that this is a case that's seen quite often. This was a 51-year-old premenopausal lady, no comorbids, presented with lump in left breast for a month's duration. On examination, had a 2-centimeter lump in the left upper outer quadrant. There are no axillary nodes. She's actually the mother of a doctor working at my own hospital. So we did a biopsy. It was a grade 1 IDC with strong ER and PR expression 8/8. HER2/neu of 1+. Ki67 was borderline at 16%. I know a lot of us would utilize different Ki67s in our practices. And there are different cutoffs and definitions for low risk, intermediate risk, and high risk. Hers was
It's frozen again. Like, yeah. Dr. Adya, are you back? I mean, like your screen was frozen. Yeah. You can.
Okay. So where did you lose me? The case?
Ki67. People take differently.
Yeah.
Yeah.
Yeah. So case. So again, excellent performance status, no family history. No. Next slide, please. So underwent an upfront surgery, left breast conservation surgery with sentinel node biopsy. And again, it was a PT1C. It was 2 centimeters, no nodes on the sentinel dissection, margins clear, no LVI. Next slide. So the question obviously is what next? You know, is this a patient who at T1CN0 strong ERPR, Ki67, which is intermediate case for only endocrine therapy? Obviously, she would need radiation. Is this a case where you would still want to consider chemotherapy, considering that she's fit and she's young and has an excellent performance status, and or she's the ideal case for a gene expression profiling as well? Next slide, please. So this is the Predict Online, which used to be called as the Adjuvant Online earlier. So we filled in the data for the patient. This is obviously at 15 years. So when we looked at the data, at 15 years, without any subsequent hormone therapy, there was a 76% possibility that she would be alive. The addition of hormone therapy added another 5%. But when you look at chemotherapy, the addition of chemotherapy added another 4% to our survival. Now, we would in our practices look at different cutoffs, 5 years, 10 years, 15 years. We also would look at different cutoffs for the benefit of chemotherapy. The general consensus is that anything more than 3% is probably an indication. So this is Adjuvant Online or Predict, the second version. And again, this is extrapolation from the UK population. But clearly this test does appear to say, or at least the algorithm does suggest that there would be benefit with some chemotherapy in a setting like this. Next slide, please. Now, what are the NCCN recommendations, particularly in premenopausal setting? Remember, she was 51, but she's premenopausal. So these are the NCCN guidelines. And when you look at the downward arrow, any tumor which is more than 0.5 centimeter, node negative, they strongly recommend a gene expression profiling. But if it's not been done, the category 1 recommendation is an adjuvant chemotherapy followed by adjuvant endocrine therapy. Now, if we were to go by this, since we haven't done any gene expression profiling so far, the first recommendation is to actually undertake chemotherapy, which a T1CN0 clearly seems to be an overkill. Next slide, please. Next slide, please. So, as I said, this is a setting where gene expression profiling comes in. There are different types of gene expression profiling tests available. So we did our own study a year and a half ago. We looked at our own data, and obviously at that time, the maximum data that we had was the other gene expression profiling test called the Oncotype DX. So we looked at 90 of our patients who were able to afford it, who underwent a strict stratification. We did a retrospective analysis. We also, in our tumor board, looked at the clinico-pathological characteristics, the Nottingham Prognostic Index, the predict recommendation, and across 3 medical oncologists tried to come to a conclusion as to what our recommendation would be for each of these patients, independent of the Oncotype DX score, and what eventually the Oncotype DX score came up with. Next slide, please. So these were astonishing results, and these went both ways. We had 52% difference in what we concluded based on Predict Online, based on clinical pathological score, and what eventually the Oncotype DX suggested. So in more than half the numbers, half the cases, the Oncotype DX score was suggesting a different modality of treatment compared to what most of us, and there were 3 medical oncologists involved, where what most of us thought would be the right approach for a patient in the adjuvant setting. And in majority of cases, we actually overestimated the risk of relapse. Majority of patients where we thought that chemo would be indicated, it was not indicated. And I think clearly, again, this is a very small data set, and now we are also including other tests that the gene expression profiling, the risk predictor scores that we have undertaken for some more of our patients, and we are looking at a much broader data set, but clearly showing that even in a country like India, a gene expression profiling for early stage hormone receptor positive breast cancer makes a difference. Next slide, please. So again, coming back to Indian patients, while at one side we are talking about 65,000 patients having early breast cancer, we also increasingly deal with patients who are younger, have probably a higher tumor burden compared to Western patients who have smaller tumors, much more no negative tumors, clearly suggesting that when you look at age, younger age, a slightly bigger tumor, you'll probably be tilting more towards chemotherapy rather than doing just hormone therapy with these patients. And that's why a gene expression profiling is a very important way of assessing the needs of the patient. Next slide, please. Now, the problem with some of these tests has been the fact that they are quite costly. Now, the general estimate is that whichever test you undertake, prognostic tests like Oncotype DX or MammaPrint that were developed in the West, or the Prosigna, that is the OncoPrecise risk predictor assay, which is in fact the only FDA approved test, all of them have the potential to identify in a better fashion the really high-risk patients in this subset of early breast cancers that are HR positive, and limit chemotherapy usage to them and avoid chemotherapy, hence the financial burden, hence the long-term toxicity in a significant majority, nearly 70 to 80% of patients who would have a lower risk on the gene expression profiling and would be able to avoid chemotherapy. Eventually, this also translates into a benefit in terms of overall quality of life. Next slide, please. So this is where Prosigna comes in. Prosigna is a test that looks at predicting the risk of recurrence. So what is it? It's a test that's done on an FFP sample. It involves the extraction of RNA through the encounter-enabled laboratory. Before the test is undertaken, the pathologist confirms that the tissue has malignancy and the patient is a right case for doing the test. And then there's the RNA analysis post the isolation. The sample is prepared and the Prosigna assay is run on the encounter analysis system, and then the results are provided. Next slide, please. Now, what the test does is 2 things. It will categorize the patient based on not only the PAM50 gene expression data, that's the genetic expression data based on the RNA analysis, also look at the clinical features like tumor size and there's a binary distribution between those patients who have a tumor less than 2 centimeter compared to those who have 2 or more than 2 centimeter. There's also a proliferation score that is taken into account, and eventually that is what generates a risk of recurrence. And therefore, Procyna is the only test that uses both anatomy and tumor biology to determine the risk of recurrence and risk classification. And based on this risk of recurrence, nodal status, Procyna determines risk classification using cutoff points related to clinical outcome. They would generate a score, and that score is something that we can utilize to decide whether the patient needs adjuvant chemotherapy or not. Next slide, please. So these were some of the studies. So one of the studies which actually looked at the Procyna score and was this study. Again, they looked at 653 patients and their long-term outcomes. They did the Procyna testing. On the left-hand side, we can see that Procyna has actually divided these patients into 4 intrinsic subtypes: luminal A, B, HER2 enriched, and basal-like. And again, these are ER and PR positive early breast cancers. And we can clearly see that based on the risk stratification, luminal A, as we expect, do the best in terms of long-term, not only breast cancer specific survival, but also distant disease-free survival compared to luminal B, HER2 enriched, and the basal-like. Next slide. And similarly, you look at the breast cancer specific survival based on recurrence score, and we'll come to the recurrence score later on. Those with the highest, in fact, those with the lowest recurrence score would actually do quite well. And we can clearly see that at 15 years, those patients who have the lowest risk actually have an excellent breast cancer specific survival. Nearly 5%, have 95% breast cancer specific survival compared to 70% breast cancer specific survival for those patients who have the highest recurrence risk. And similarly, when you look at distant disease-free survival, 95% patients free of distant relapse in the lowest risk score compared to about 65 to 70% patients who are distant disease-free at 8 years with the worst scores. So clearly there's a clear separation of curves for the lowest score and the highest score. And what we can also see that for the node negative setting, the blue curve, which is the lowest score, the green curve, which is the intermediate score, are actually quite close together. And there's a clear demarcation, clear separation of the red curve, which is the highest risk of recurrence, the highest ROR score. Next slide, please. In fact, they also compared, and again, as I said, while we would want to compare Procyna with the Oncotype DXs, the EndoPredicts, there are a lot of patients or a lot of clinicians who would actually be looking at the IHC with Key 67 score, the comparison with the Predict Online, and what we can clearly see that even when you compare it to the more conservative tools of prognostication, the IHC4, the Adjuvant Online, or the what we call as the Predict version 2, Procyna actually is able to predict much better the long-term outcomes, the long-term disease-free survival, the distance recurrence-free survival compared to all the other tools. Next slide, please. So Procyna has been approved by all the major guidelines, the NCCN, ASCO, ESMO, NICE, and the Singapore guidelines. Next slide, please. And clearly, NCCN 2023 also highlights that Procyna, the PAM50 gene expression profiling, is an approved and preferred testing for prognostication for early breast cancer patient with hormone receptor positive status. Next slide, please. Next slide, please. So these are the comparison of the different modalities. We look at Oncotype DX. We talk about OncoPrecise, which has 50 classifier genes and 8 housekeeping genes, uses the RNA sequencing by nanostring technology, takes into account clinical parameters, is FDA approved, and is comparatively a lot more cost effective compared to the other tests, MammaPrint, which does not take into account the tumor size, is not FDA approved, is much more costlier compared to Oncotype DX, which probably has the most robust long-term data, but again, does not take into account clinical parameters, and again, is one of the most costly tests. And CanAssist, which is a 5 biomarker test. It's an IHC-based test. It does take into account the clinical parameters, but to some it may appear very simplistic. Again, I'm not going to comment, but clearly what we can see from the data is that the OncoPrecise is a fairly robust test with quite a robust data and a clear separation of curves with risk prediction scores. Next slide, please. So this is how the report looks like. So the node negative category has been divided into 3 scores. The 0 to 40 is the low risk score, 41 to 60 is the intermediate risk score, and 61 to 100 is the high risk score. And there's a clear-cut recommendation for chemotherapy for more than 60. 40 to 60 is where you can individualize. Less than 40 is clearly hormone therapy. It's also approved for N1, that is 1 to 3 nodes, where bifurcation is at 40. So 0 to 40 is low risk and 41 to 100 is high risk. Next slide, please.
Sir, 2 more minutes.
So coming back to our case, coming back to our case. So this patient with a very early 2 centimeter tumor, which is strongly ER and PR positive. Next slide, please. We sent her ProSigna testing. Next slide, please. And this was the score. So her score was 25.45, which means that her 10-year probability of distant recurrence is less than 10%. And clearly, this means that she will be able to safely avoid chemotherapy and go on to receive radiation and hormone therapy. Next slide, please. So I quickly conclude, nearly 65,000 Indian women with breast cancer are diagnosed in early stages. Despite the modest benefit of chemotherapy in node negative, most patients are still considered candidates for chemotherapy because just based on clinico-pathological features, we are unable to prospectively determine which patients have the greatest risk of recurrence and most likely to benefit. But the actual need is limited to anywhere between 10 and 15% of patients where there is a risk of relapse and therefore chemo is strongly recommended. The other 85% do not need it. Gene expression profiling is increasingly used to determine the risk of breast cancer recurrence and aids individualization of therapy. Amongst various tests, OncoPrecise risk predictor is an important way to classify patients into prognostic subgroups, and the prognostic scores clearly showing the difference in outcomes, with the lowest score associated with less than 10% risk of long-term relapse compared to a greater than 20 to 30% risk of relapse for the higher risk scores. And the test is approved by US FDA. The test is comparatively cheaper compared to some of the more costly Western tests. And our own experience will grow as we use this test more often.
30 seconds.
With that, I'd like to thank the organizers. Romila, I'm done. Thank you very much. Thank you.
Thank you. Thank you so much, sir. You indeed touched very significant and practical points. And now we next move on to our next talk that is sponsored by AstraZeneca, that comes from Dr. Anil Tarigupala. He is a pathologist from Sikandarabad. And so you can please take it up. HER2 new low stands tall among all subjects. Thank you.
Thank you. Thanks to the organizers. And also I would like to acknowledge AstraZeneca for the slide set. And as pathologists, we are ever trying to catch up with the requirements of the oncology teams, because our eyes are also a limitation and we need to involve more technology as we go forward. I'm not able to see my slide set.
Anita, slides, please.
Yeah, just a second, sir. We are sharing it. Just a second.
Sure. So this, I think there is already a talk lined up by a senior oncologist later. So the medical oncology part of it, we'll just brief through, but I would like to concentrate more on what are the limitations in pathology as of today and what we need to brush up with our practice as we go forward to satisfy the requirements of oncology teams. Next slide. Yeah, so HER2 is one of the 4 receptors of EGFR family. It's a human epidermal growth factor receptor family. It is involved in regulation of cell growth, survival, differentiation via initiation, and multiple signal transduction pathways are involved in this. Now, it is a gene which is located on chromosome 17, and normal tissues express a very low component of HER2 on the membrane, cell membrane of the cells. In HER2 positive breast cancers, you either have amplification of the HER2 gene, which drives protein expression, and on the surface, you can identify the protein expression increase through immunohistochemistry. So usually there can be 25 to 50 copies of HER2 gene per cell, and this amplification can, because you have a translation and which can result in millions of copies of HER2 receptors driving the tumor forward. Next slide. So
sorry
the
to
role
interrupt,
of,
sir. Can we have the slide in the full screen, please?
so what we know about HER2 is that its amplification and overexpression causes inhibition of cellular, all factors that can cause progression of the cancer, initiation and progression of cancer, including angiogenesis, proliferation, invasion, inhibition of DNA repair, metastatic potential, and increased cell survival. And this is a negative prognostic factor by itself in breast cancer. Next slide. I think, is it full screen, madam?
So actually, I believe it's in the PDF format. So there's some
I had sent a
problem.
PPTX also. I had sent a PPTX.
Uh-huh.
Anyway,
Anita,
doesn't matter.
and the technical team.
That's okay, madam. So HER2 testing, we know that across all practice guidelines, it is a requirement to include HER2 testing in all newly diagnosed and metastatic breast cancers. It is a requirement in NCCN, NASCO, ESMO, and all guidelines that we know of. Next slide. So and for identifying this amplification or increased expression, we use two technologies. One is immunohistochemistry, which is the predominantly first line, and you also have in situ hybridization, either dish or fish. Fish is the more reliable technique in this particular evaluation. So, all new primary and newly diagnosed metastatic breast cancers, to inform treatment decisions, we perform this test. HER2 being a prognostic, predictive, and therapeutic marker in invasive breast cancer. One thing to note is that whenever a pathologic evaluation is done on breast cancer, you should include, the pathology lab should make sure that the pathologist evaluates only the invasive component. The DCIS component is not to be evaluated and reported in this case. Now, in the first line is of identifying expression of HER2 receptors is by immunohistochemistry, which is a simple and commonly available technique. And you also have HER2 gene amplification assessed by in situ hybridization as in fish. Or sometimes in 2018 guidelines, we require to refer to both the techniques in certain conditions. Next. Now, when it comes to immunohistochemistry, we know that we are all eyeball indexing. We are not actually using digital pathology or high technologies we rely on our eyes. And you can see that IHC 0 refers to zero staining or minimal staining in less than 10% of the tumor cells. IHC 1 plus is graded as graded when it is incomplete, barely perceptible staining, membrane staining in more than 10% of the tumor cells. 2 plus is moderate, complete membrane staining in more than 10% of the tumor cells. And 3 plus is self-obvious with very dark and very prominent staining, including all the more than 10% of the tumor cells. And wherever you have IHC 2 plus, IHC 0 and 1 plus is traditionally called as negative. IHC 2 plus is equivocal and referred to fish or in situ hybridization studies. And some of them turn out positive by fish criteria. And some of them are classified as negative. So IHC 2 plus is a gray zone as of today. So 0 and 1 plus are considered as negative. So there is no distinction between 0 and 1 plus as far as clinical implication as of today is concerned, as of yesterday probably. Next slide. So in fish also, there are two things that we do in the laboratory. One is we use two markers. It should be a dual signal fish as compared to a single marker fish. So there is this particular gene is located on chromosome 17. So we have a probe which marks, like for example, in this case, the orange color marks the HER2 gene, and there is a green signal which marks the CEP17, that is centromeric enumeration probe, which counts the number of 17, chromosome 17. So you take a ratio of HER2 signals to 17 chromosome 17 signals, and if the ratio is more than 2, it is considered positive. Where the ratio is less than 2 and signals per cell, that is orange signals or HER2 signals per cell are more than 6, it is still considered positive. When you have a clear ratio less than 2 and total average signal copy number for HER2 in a cell is less than 4, it is negative. But there is a gray zone in fish also, as identified in 2018 ASCO and CAP guidelines. HER2 to sub-17 ratio of less than 2 with an average copy number of more than 4 and less than 6 signals per cell is referred for further analysis. Either you do additional testing on another block, or you do an IHC, identify areas where there could be some slightly higher intensity of staining, refer it back to FISH. To and fro, you have to discuss with between immunohistochemistry and FISH to report it as either way. So there is a lot of gray zone. So what happened next is, next slide. So we know now that with the evolution of guidelines that have come in for a pathologist to classify these as negative 0, 1+, 2+, 3+ on immunohistochemistry and positive or negative on FISH, which again has an equivocal component now. So we know that it is not something which is grade 1, grade 2, grade 3, grade 4. It is rather a continuous spectrum of slightly increasing HER2 expression from negative to strong staining and negative to high amplification. Next. So currently, using the current methods of immunohistochemistry and in situ hybridization, 80 to 85% of patients with breast cancer are classified as HER2 negative. That is as per the 2018 guidelines. If we classify IHC 0, IHC 1+, and 2+ IHC with ISH negative are considered negative, and they are not eligible for HER2 targeted therapy. The currently available HER2 targeted treatments have not proven to be effective in patients with low levels of HER2 expression, that is 0 and between 0 to 1 and 1+. Those we don't have evidence to show that with the existing therapies it is effective to treat them. Next. So what when we evaluate the number of patients that could have low levels as defined by 1+ or 2+ on IHC with in situ hybridization negative in a 2+ case, these are the definitions for a low level expression of HER2. Now, the clinical characteristics are still being established, but the early data suggests that the tumors frequently are hormone receptor positive present. I mean, that we'll see in the next slide, what percentage are positive. But you see in this that HER2 negative, the 0 is considered as a separate entity. 1+ and 2+ in situ hybridization negative cases are classified, can be classified. I mean, when you study them as a group, you can probably classify them as HER2 low, 1+ and 2+ on IHC with ISH negative. And usually, next slide. Now, when you see these tumors, HER2 low tumors, when they were studied for their prevalence, it was seen that they were significantly more frequent in hormone receptor positive versus hormone receptor triple negative breast cancers, with 65.4% of hormone receptor positive cases showing low expression of HER2 by the parameters that we have discussed, and 36.5% of triple negative breast cancer showing HER2 low expression. So overall, if you see 68% of HER2 low tumors, they have IHC 1+, and I mean 2+ is equivocal ones. The ones which are classified again as low HER2 are around 32% of the cases. Next slide. So there is an unmet need for HER2 low advanced breast cancer. Next slide. So what is the reason? The reason being that you have either HER2 positive or HER2 neo negative cases, based on the test algorithms that we have been using so far to determine the HER2 receptor status or in situ hybridization status. The positive cases that benefit from anti-HER2 agents which block the HER2 pathway hyperactivation due to HER2 amplification and overexpression, while HER2 negative cases, they do not have the benefit of clinical actionability with anti-HER2 agents. Next. So there have been various studies. I think all these things I need not go in detail because the oncology team already will be discussing all these. But overall, we know that whether it is hormone receptor positive, HER2 negative, or HER2 negative hormone receptor positive, overall survival is not very good with this subset of cases. Next slide. The next slide, please. So patients with HER2 low advanced breast cancer are currently treated as HER2 negative hormone receptor positive breast cancer or HER2 negative hormone receptor triple negative breast cancer, depending on the hormone receptor status. But currently there is a French guideline which says that HER2 status assessment in breast cancer should also include a HER2 low category because of some emerging therapies. Let us see what they are. Next. Now, there are various mechanisms that are involved in, like, for example, trastuzumab, all of us know that it inhibits the activation of HER2 signaling pathway and causes, in cases with high amplification or in cases with overexpression of HER2. In cases with low expression, you also have immunotherapies, and you have currently an upcoming molecule, which is an antibody drug conjugate, which is trastuzumab deruxtecan, which is a molecule which conjugates anti-HER2 antibodies through a cleavable tetrapeptide based linker with cytotoxic topoisomerase 1 inhibitor, which is an advanced molecule. And this destroys this induces lysosomal destruction of the HER2 receptors and also releases the high payload of cytotoxic topoisomerase 1 into the cell, which goes further on to prevent the DNA replication in the nucleus, thus preventing tumor progression. So this is the reason why, this is one molecule which has been studied in HER2 low breast cancer, and evidence is emerging that it is effective in cases with HER2 low breast cancer who may not have too many molecules to target. Next.
So 3 minutes.
Yeah, sure. So we'll skip this. This probably will be discussed in the next slide. I will go to the next one, please. Yeah, so now the pathologist's point of view, we'll have to identify cases which are zero, absolutely no staining, faint staining, to split hairs between 0 and 1+, and also identify 1+ from the 2+. I mean, equivocal. So there are going to be, currently the requirement is also going to be to identify HER2 low reliably, to be able to distinguish 0 from 1+, which we were not very much bothered in the past. Now we have to bother about it, and probably in the upcoming trials, there will be a requirement to have ultra low, which is beyond the resolution of our own 2 eyes. We'll probably require more technologies. Next slide. So next slide. Next slide. So let us see from a pathology point of view, there are a lot of pre-analytical. See, in the laboratory, we can standardize our techniques and do it. But before the sample reaches the laboratory, there are certain things that happen to the tissues, whether it is processing, putting in the fixative or transport time, fixation time, all those things. So the pathology team must take care of this pre-analytical specimen processing also to make sure that the errors are minimized in the downstream process in the lab. Next slide. So choosing a prime, we all know that there is certain amount of tumor heterogeneity. 43% of tumors in breast cancers have heterogeneity of HER2 expression. Through various studies, we know that it's around 20 to 43%. So quite heterogeneous tumor. So core needle biopsies may not be entirely representative, and they also have edge effects and cross artifacts. So when further on down the line, if you have an excision biopsy with grade 3 tumor, probably you should test for HER2. Sure. Next slide. So when you take a metastatic site deposit, there are certain challenges, including a bone deposit, which needs to undergo through fixation and decalcification that compromises the quality of immunohistochemistry and FISH. Next. Yeah, the other thing is sample handling. I mean, if the sections are cut and not stained immediately, it can also deteriorate, and also archive blocks can have lower intensity of staining that is revealed on testing. Next. Once the tissue is removed from once the biopsy is taken, it should be immediately put into 10% neutral buffered formalin, and adequate fixation of up to 6 hours and not more than 72 hours is to be ensured, to ensure that downstream processes are crisp. Next.
Sorry, but time is up. Can you please wrap it up?
Yeah, sure. So let's go down. Okay. Next slide. Next slide. Next slide. Yeah. So in NCCN guidelines also, the current guidelines say the 2023 guidelines require us to start looking at low level of HER2 expression, or to identify HER2 low in the cases that we get in the laboratory. So there is always a question of technology and techniques involved. Next slide. So there is also a requirement to standardize not just the processing in the lab, but also evaluation by the pathologist at what magnification. All these things probably will come because ASCO and CAP guidelines, they get revised whenever therapy change is there. And but it takes time for consensus to build and a new guideline to come. But these are probably going to be standardized in the next one. Next. So these are other questions that the clinicians will know. You can go down to the, slide number 32. So it's been known that HER2 status also converts. So there is a conversion rate of positive to negative in 21.3% of cases and negative to positive in 9.5%. So you should also account for probably retesting. It's recommended to reevaluate receptor status, including HER2 in metastatic lesions wherever possible, because there can be conversion of HER2 status. Next slide, last slide. Last slide, next one. So we know that 15 to 20% of invasive breast cancer cases are HER2 positive as of today's definition. Tumors with low level of HER2 expression, which are HER2 low, currently classified as HER2 negative, have detectable HER2 expression of IHC1+ or IHC2+ and non-amplification of HER2 gene by IHH. More effective treatment options are needed in cases with advanced HER2 negative breast cancer, like the new ADCs which are coming through, and they have shown encouraging response in the initial trials. Robust controls are on pre-analyticals and analyticals. From the laboratory point of view, we need to standardize and use the right kind of reagents and processes, and also evaluation techniques to ensure that the results are relevant in clinical practice. Thank you.
Thank you. Thank you, Dr. Anil, to have elaborated the low HER2 new topic to all of us. I'm sure everybody has some concepts cleared, especially our students. Now we quickly proceed towards the panel discussion, nuisances in management of DCIS, which would be moderated by Dr. Neha Chaudhary, surgical oncologist, Kolkata. And with her, the panelists would be Dr. Sudham Sadangi, surgical oncologist, Bhubaneswar, Dr. Manjunath, surgical oncologist, Cuttack, Dr. Dilip Kumar Kara, surgical oncologist, Bhubaneswar, Dr. Prakash Swain, radiation oncologist, Cuttack, Dr. Subhashish Mishra, radiation oncologist, Bhubaneswar, Dr. Sri Gopal Mohanty, medical oncologist, Bhubaneswar, Dr. Denny Gupta, medical oncologist, New Delhi, Dr. Manas Pesak, pathologist from Bhubaneswar, Dr. Manjari Bakre, molecular oncologist from Bengaluru. Dr. Neha Chaudhary, please take it up now.
Okay, hello everyone. I'll just share my screen, just a second. So I hope my screen is visible.
Yes, it is.
Okay, so hello everyone, I'm Dr. Neha Chaudhary, and we'll be having a panel on nuances in management of DCIS. My panelists have already been introduced, and let us start. Just a minute. So my first question is to our pathologist, Dr. Manas Pesak, and Dr. Manjari Bakre is a molecular pathologist. So how would you define DCIS? On microscopy, what features would make you call it DCIS? What are the additional stains? And how would you differentiate DCIS from ADH and other similar lesions? So,
yeah, I mean, hi, good evening, everyone. As far as ADH and DCIS is concerned, actually, this is a tricky lesion where on morphologically, it is sometimes, often, in fact, very difficult to take a call. So we put usually a panel of IACs to decide in those cases, like ER and presence of P63 and the pattern of how and CK5/6 we take into account. Based on that, we decide if it is ER is diffusely positive and there is loss of P63 is there. So we decide in the favor of DCIS rather than when it is a patchy kind of ER positivity and is P63 is often present, then it is more in favor of ADH. So that is how it is decided.
okay, great. Manjari ma'am, you would like to comment on anything?
Yeah, no, I completely agree with Dr. Manas. It is the hardest part is diagnosing DCIS, and it often gets missed out. So I think, as Dr. Manas alluded, definitely the special staining, special IHCs with P63, CK56, SMA or calponin would help, but also good histology like ductal involvement, cellular atypia, looking for comedonecrosis, architectural distortion of the ducts, presence of calcification, microcalcification, and ensuring that the basement membrane is intact and there is no invasion. These are really critical aspects of diagnosing DCIS.
Perfect. I think that was completely well put. So moving on to our clinicians, I think we will start with our surgical oncologist. In India, the number of DCIs we see would definitely be lesser than Western countries because we do not have a national screening program. Even the presentation would be different. So quickly, Dr. Sudham Sadangi, Dr. Manjunath, and Dr. Dilip Kumar Kar, what is the percentage of patient you would see as pure DCIs in your clinic? And approx number you've seen in last 2 years? Just the numbers.
Good evening, everyone. I'm Dr. Sudham Sadangi. For last 2 years, maximum pure DCIS case, I've seen like 4 to 5 cases only. And the percentage will be, I think, less than 2 to 3% pure DCIS in my clinic.
Okay. Dr. Manjunath?
Yeah, same. It is the same, like from my side also, in a month, if I see some 10 to 12, in a year, like overall, maybe 3 to 4 cases I would see. It accounts to maybe around 2 to 3%.
Okay. And Dr. Kar, what about you?
Yeah, in last 6 years, I have seen only 3 cases. Out of them, 2 are palpable DCIS. 1 was non-palpable. And for last 6 years, 1 patient has undergone mastectomy and only on endocrine therapy. The 2 palpable DCIS, they are hormone negatives. They have undergone mastectomy and only on follow-up. And one of the palpable, which was 5 centimeter, where the Manas has reported, it's a DCIS. He has, after mastectomy, has undergone radiation, not by me, by the radiation oncologist. Reason behind it. Thank you.
Okay, great. I think even I have seen only 2 or 3 in last 2 years. It was difficult for me to find a case, in fact, to present. So DCIS, more than in Western countries, more than 25% of mammographically detected cancers are DCIS. And the incidence of DCIS has increased from 94 to 2014, from 22.3 to 34.3 per lakh. 1 in 1,000 mammos will detect DCIS, and around 20 to 30% of this DCIS will progress to invasive cancer. What are the common clinical presentations? As this Dr. Kar has already told what are the presentations of his case. Dr. Sadangi, Dr. Manjunath, what are the presentation of DCIS in your cases?
I think most cases present with lump only, because only 2 patients who were on follow-up for previous breast cancer of the same side, the opposite side breast came out to be DCIS on screening. Otherwise, all of my patients came with a lump only.
So yeah, so we are probably seeing much more palpable DCIS than Western countries, and it has been seen that palpable DCIS is probably more aggressive than screen detected. They follow a different pathway and they have a different molecular subtype. The common presentation, apart from screen detected palpable, would be nipple discharge and Paget's disease. Coming to our case, this was a 44-year-old premenopausal lady, no comorbids, no family history, came with right breast lump since 10 months. And she had a 3 centimeter very vague right inner central lump, which was a little close to nipple areolar complex. There were no palpable nodes in the axilla. Opposite breast, axilla, and supraclav were clear. So because it was a vague lump, I've made a larger area, marked the larger area. So Dr. Sadangi, Dr. Manjunath, one of you, what would be your next step? Dr. Sadangi, please.
Yeah, I will think of mammography first. If mammographically the lesion is clearly detected, then no need of MRI. If it is doubtful, and then I can go for an MRI.
So I think perfect. So this was the mammography that we saw. We can see that it's a little bit dense breast, and we can see that in the right inner central area there's an architectural distortion with microcalcifications. I've zoomed the microcalcifications for you to see properly. We also did a MRI breast because the breast was dense and it showed an ill-defined area of architectural distortion, multiple uptake area and non-man's enhancement with wash-up type of curves, but it was all limited to an inner central area of 5 centimeter. On ultrasound, we were also able to see the lesion with the microcalcification, as you can see. So, as sir said, right, if it is a dense breast, only then MRI, otherwise probably the role is not that strong. NCCN also recommends the same. The role of MRI would be to pick up non-calcified DCIS more as enemy. It has a high sensitivity for high-grade DCIS, but it is not great at picking up low-grade DCIS because the vascularity is less. And also, MRI always overestimates the extent of DCIS, leading to higher mastectomy rates without any benefit on margin positivity or re-excision rates. So, core biopsy versus VAB, what is your preference? Dr. Kar, what would you prefer, core biopsy versus VAB? Suppose
Definitely,
you
have... I don't have a personal experience of VAB, but definitely VAB is more challenging, and you get the VAB, the positive effects are out of the negative. You get a more chunk of tissue, single, and you don't have to repeatedly put the core needles repeatedly. And in a single, you get multiple tissues and sizable tissues, and on a small lump, it is quite beneficial. But the only thing what we use in the 14 gauge needle in the VAB, we have to slightly go for a sono-guided with a vascularity. Sometimes it creates a hematoma if the 14 gauge needle, if it hits the vessel.
Yes, I completely agree with you, sir. VAB does have a problem of creating hematoma, so proper compression is very important. And another important thing is that VAB is available in very few selected centers in our country. So probably even today, most centers would go with the core biopsy. The benefit of VAB is, as you said, more tissue. So the upgrade rate of DCIS to invasive cancer is much lesser. It is 10% compared to 15 to 36% in core needle biopsy. So, Dr. Beshak, when you get a core for your histopathology, what are the things that you would tell the surgeon that please take these precautions? What is necessary, especially if it is a non-palpable screen detected DCIS with macrocalcifications?
Yeah, I mean, I would definitely invasive component if it is there or not. Have to find out. I mean, if actually the kind of areas they have got in mammo, whether suppose they have got some areas of calcification that is present in the tissue or not, that will tell them exactly whether they have gone to a particular area they were targeting in those areas. So apart from that, the general comment on the DCIS grade and other thing, I'll be I can give those kind of information like architectural pattern and the nuclear grade and other thing.
Yes, perfect. So I think what is important that we use a 14G needle, not a 16G needle, so that we get proper tissue thickness. Long unfragmented core, we need proper fixation. And if we are picking up only microcal on stereotactic biopsy, it's very important to do a mammo of the biopsy specimen and document that the microcalcifications have been picked up. Also probably inform our pathologists that these are the cores which have the microcalcifications, because that will help in proper histopathology. So
also important is the grossing technique as suggested by the Tata Group. The grossing technique is very, very important.
Yes, I think serial segmental cuts.
This is, I think we are talking about guided biopsy, true cut biopsy, sir.
No, in VAB also. The VAB grossing technique is very important.
I think in VAB also, sir, you will be getting tissues in pieces. I think.
Yes, Web also we get tissues in pieces. Anyways, we'll move on. So our patient had a USG guided core biopsy. It showed DCIS, clinging solid pattern, high grade, no necrosis, no evidence of invasive, ERPR negative. So my question to our medical oncologist, Dr. Mohanty, Dr. Vini Gupta, at this step, would you like to check HER2 receptors on the biopsy specimen?
So, hi, I'm Sri Gopal. Good evening, all. For in our clinic, we routinely don't do HER2 receptor status in DCIS, particularly because of lack of therapeutic implication. And so far, the literature says that this HER2 positivity, although it is higher in DCIS compared to invasive breast cancer, almost a double incidence, almost 30 to 40%. But still, it is somehow is linked to the initial, tumorigenesis. It's not much. Even anti-HER2 treatment in previous literature is not associated with any breast cancer recurrence benefit of using anti-HER2. So, because of lack of therapeutic benefit, we are not routinely doing HER2 status.
Okay, so as sir said, no therapeutic benefit, so no point in doing it, which was proven by the NSPB 43 trial. Moving on, so coming to the surgeons, what surgery do you think would be a feasible option to this patient? What would you offer? So Dr. Manjunath, can you please tell us what would be the surgery?
Yeah, we can discuss actually both BCS option and like mastectomy. If you are going for mastectomy, then SLNB has to be done. Otherwise, lumpectomy and frozen section for the margins and like any invasive component has to be checked.
Okay, and where would you do SLNB if it is lumpectomy only routinely for DCIS?
No. Only in mastectomy cases we can go for SLNB. Any addressing of the axilla is required only when you are doing a mastectomy. Otherwise, like a lumpectomy would suffice unless any invasive component is found in frozen.
Yes. Okay. So, Dr. Kar, would you differ?
No. Particularly in this case, let me define very clearly. It's a palpable DCS.
Yes.
And more than 3 centimeter. So probably, if we consider the Tata paper, probably RO is seeing more aggressive disease in this. And RO is seeing after grossing more macro invasion. So in the Tata paper, you will find 40% cases, they are with macro invasion. So we need to consider separately for this. So in this case, I will go for the same Manjunath, but the grossing technique and the identifying foci of micro invasion, macro invasion should be properly. I should take help of my pathologist. And in this case, if the patient is agreeing for breast conservation, because he is a young patient, less than 40, 45, I'll go for the breast conservation, some form of reconstruction if it is required.
Thank you, sir. So SLNB, the GASPO guidelines say that you do SLNB with mastectomy. With BCS, you can do if it is more than 5 centimeters, there's a clinical radiological suspicion of invasion, or if the location is such that it might compromise the drainage pattern. Skin sparing mastectomy can be offered. However, the 8-year local recurrence is higher, 5.4% versus 0%. Our patient was keen on conservation, so we did a right breast lump wide excision, did a specimen mammo and frozen, did a mini LD flap and SLNB because she did not want a repeat surgery. So is the follow-up picture. There's a small crescent of skin here. I had to remove skin here because it was close. So Dr. Besak, Dr. Manjari Bakre, what is the role of frozen section here for diagnosis of invasive disease and for margins? How accurate you think it is?
Ma'am, frozen has definitely has got a role. As far as margins are concerned, we can comment on whether actually on the margin there is any DCIS component is sitting there or not. And of course, if there is any doubtful areas while when they have taken out the lump, we can sample those areas, and at least we can look for any invasive component is there or not. And I don't think we will be able to comment on extensive DCIS whether that is there or not. However, we try to give multiple sections where if it is a significant DCIS we are getting, we can at least comment upon the extensive DCIS component. We can at least alert the surgeon regarding.
I agree with you, sir. We did frozen in spite of its limitations because any resurgery, if avoided, is useful in our setting. Anyways, this patient had 4 centimeter disease, DCIS high grade, no invasive component, margins clean, nodes negative, ERPR negative. I'll just skip ahead. The ASPO guidelines for margins says that margins of at least 2 mm for DCIs, irrespective of risk factors, is needed, and there's no benefit of margins more than 2 mm. Individual discretion is needed for negative margin, but less than 2 mm, and positive margin if there increases the risk, and it cannot be nullified by RT or hormone therapy. DCIs with microinvasion should be considered like DCIs, and 2 mm margin should be taken. So Dr. Mohanty, Dr. Denugupta, what is the role of chemo and endocrine therapy in this patient? If endocrine therapy, what would you prefer? What's the duration? Dr. Mohanty, please start.
Yeah. So in these cases, like HR positive cases, we will definitely go for endocrine therapy. So if it's a premenopausal, I will choose tamoxifen. If it's a postmenopausal, less than 60 year, I'll go for anastrozole 1 mg daily for 5 years. And if it's a more than 60 year with any osteopenia, most of our Indian ladies more than 60 years postmenopausal will be having some sort of osteopenia, osteoporosis. There I will choose tamoxifen over aromatase inhibitor. And yes, so for both of these agents, tamoxifen or
Dr. Gupta, 5 mg tamoxifen, there is TAM1 trial. Would you what would you prefer, 20 versus 5?
No, I think right now we have been using 20 milligram tamoxifen as a standard of care. We have not switched to 5 mg as of now. I don't think there's any robust data as such.
So NCCN also says that low dose is an option only if 20 mg is not tolerated.
Wait, one point. Yeah. So this TAM1 data, 10-year follow-up data is now recently published in JCO. So which is showing almost like double the recurrence rate at the end of 10 years. So now this is what you have shown the 5-year data, 11.9% versus 5.7%. But in this 2023 published data in JCO, they are showing that at 10-year median follow-up, this with 5 mg, there is a relapse rate of 11% almost.
So 5 mg is not an option.
At 20 mg, 10-year data is 5% relapse rate. Whereas with 5 mg, it is 11%. So almost doubling the recurrence rate. So although this is a cross-trial comparison, but yeah, so far there is no head-on comparison. But so far 20 mg is the standard.
Okay. So let us come to.
Sorry to interrupt. Just letting you know.
So role of radiation, I've come to radiation, so hopefully I should finish. Dr. Swain, Dr. Subhashish Mishra, what is the role of radiation? This is a huge debate, and I think this itself needs an entire panel, the role of radiation in DCS. But quickly, sir, would you give radiation in this patient? Dr. Swain, please.
Okay, ma'am, this case, we know in DCIS, the standard of surgical care is breast conservation. So for the remaining breast, we definitely need RT for as a generalized rule. There are exceptions and there are cases where we can omit RT, but for a standard care, all the BCS and BCS cases, we have to add radiation to the remaining breast. We don't give lymph node basins any radiation here, only to the breast and boost to the lumpectomy cavity.
Yes, so as a standard, I agree radiation to all because 50% relative risk decrease is there. However, there's no survival benefit. Dr. Subhashish Mishra, would you give a boost to this patient? And would you consider APBI? In what would you consider APBI?
Good evening all. Dr. Subhashish here. In this case, particularly this is a case of DCIS post-lumpectomy and it was in the high risk category. So considering the size and the ERPR strategy is negative, so this is a high risk category. So we will give the whole breast irradiation followed by tumor bed boost. So the boost is omitted in only case of low risk diseases. So whatever distance we have to keep the tumor burden reduced. And among your epidemiology, it is a much debated topic. FPBI is again referring particular indication of disease of early stage DCIS, particularly that is mammography related size, age, and ERPR status criteria.
Okay. So, Dr. Swine, is there any group where you would avoid RT?
Yes, ma'am. In many cases, like in elderly females and in people in ladies with a lot of comorbidities, and when we are dealing with low risk diseases, very small diseases, margins are enough. So in those cases, we can safely omit RT.
Okay. So now there is a gene recurrence score, Oncotype DX DCIS. Dr. Manjari Bakre, could you please tell us about it? And also, ma'am would like to share 2 slides, so she can do that.
Yeah, sure. Thank you so much.
I'm going to stop sharing, ma'am.
Yeah, perfect. I hope you can see my slides.
Yes, we can.
Okay, I'll just make it.
So requesting the speakers.
Yes. So thanks, Dr. Neha, for the question. So in DCIS, the question is really which lesions are going to progress to invasive, and there have been these kind of prognostic tools like Predict, etc., like VNP, the Van News Prognostic Index or Patient Prognostic Score. But more refined molecular signatures are there are 2 mainly on the Oncotype DX, as Dr. Neha said, and there is also one which is actually more utilized. It's called Decision RT, and it is both of them are real-time PCR based. Both of them look for 7 genes, and the genes are different. There are only 2 common genes, P67 and progesterone receptor. So what I felt when I read this literature is the Decision RT molecular assay has a better edge in deciding on the high risk, low risk, because it not only includes proliferation genes, which is what Oncotype DX DCIS covers, but also immune response genes and invasion genes, and of course the hormone receptor genes. So that's why I felt Decision RT has an edge, and the Oncotype DX has also refined its own test by adding age and tumor size along with these 7 cancer-related genes. And these molecular signatures are indeed useful to give optimal treatment in DCIS with respect to whether their patient should get radiation beyond DCS or not. However, there are no such studies in the usefulness of hormonal therapy, and I wish they would conduct some things. Now, coming to how do they help? So as per the meta-analysis, as I have cited in this paper, they have really conclusively shown that Decision RT is, as per Decision RT, if the patient is stratified, the tumor is stratified as high risk DCIS, then the BCIS, so BCS plus radiation versus BCS, the hazard ratios are certainly a lot more lower and significant for not only invasive breast events, but total breast events as well. This, the p-value was significant in both in high risk, whereas in the Decision RT low risk patients, if you avoid RT, the hazard ratio was 0.62 and or 0.58 for both these invasive recurrences or total breast events, and it was statistically not significant in both cases. What is trying?
Sorry to interrupt, but then we are done with the time. Can the
Sure.
speakers
I'll take 2 more minutes.
Yeah, sure.
Yeah, so just to summarize, the Decision RT high-risk patients do have a reduction in the absolute risk of invasive recurrences, local recurrences, by about 12 to 20% by addition of RT. And Oncotype DX also had similar results. However, they have 3 risk zones, low, intermediate, and high. And once again, just like in the IDC, so the intermediate risk patients do have the same issue, whether they should take RT or not. And the data is not that well published on Oncotype DX. So that's why my recommendation, if you want to go for a decision prognostication in DCIS, I would recommend Decision RT.
Thank you, Dr. Bakre. Can I have my screen on back?
Sure.
So, So Oncotype DX has already been dealt for. Follow-up would be 6 to 12 months for 5 years, and then annually with a yearly diagnostic mammography. And this is my last point. It is a question of, are we over treating DCIS? We have seen that even though the incidence has increased from 8 to 25% with screening mammo, there is no reduction in breast cancer specific mortality or in an incidence of invasive cancer, which is an indicator of over treatment. So is surveillance only an option? So there is a precision group, which is there are 4 trials going on: LORD, Comet, and Loretta, all of them looking at active surveillance versus treatment and outcome data. Once the results are out, we will be more clear as to what subgroups can be offered surveillance only. Quickly, all the panelists concluding remarks, 1 line each in this order. So, Dr. Sadangi, please start.
The concluding remark is that are we over treating the DCIS is the confusion right now. These 4 trials will give a clear vision whether we have to give the RT. Otherwise, surgical point, it is same, the breast conservation surgery or mastectomy with SLNB.
Thank you. Dr. Manjuna?
Yeah, surgically, I think all the things are clear. Only thing is like adjuvant treatment, to reduce the recurrences, and at the same time, same thing, like over treatment can be avoided. Like we should have more research on that, and we should do. Thank you.
Dr. Kar, what would you like to say?
Yeah, I like to present one of my case just 6 years before. I did a skin sparing mastectomy with a tram flap, free tram flap. So margins were clear. The patient was hormone negative. It was a palpable DCIS, 4.5 centimeter. No radiation was given. Low axillary clearance. At that time, I didn't do sentinel lobe biopsy. Only thing, after 6 years, he has a small recurrence in the skin. I got astonished. Then I got a wide excision. This is my experience.
Thank you, sir. I think even I have had a case where it was DCIS and I was planning a skin sparing mastectomy, but while operating only, I could feel nodules on the skin. And then we converted it to a simple mastectomy. Anyways, Dr. Prakash Swain, your comments.
Ma'am, for DCIS cases, I believe we should have more and more tests to avoid radiation as much as possible. And definitely we are moving towards that. But wherever it is required, I think more advanced techniques and APBI are certainly a way forward.
Okay, thank you, sir. Dr. Mishra.
As of now, in DCS, what we have data and what we know, RT radiation as the adjuvant treatment is indispensable, particularly in the type of cases we get in our clinical scenario. The US scenario is a bit different because they have screening mammography, and they have mammographically detected DCS prior to the patient any symptomatic presentation. So it's
we are seriously running out of time.
Okay, so one line, sir, quickly your comments. Dr. Deni Gupta, Dr. Minus Pesak, Dr. Bakre, just one line each. We need to stop here, otherwise it'll be very late.
I would recommend please do a prognostication test when you think the patient may have a high risk.
So prognostic test. Dr. Baisak, what would you say?
I think TrueCut has a very limited, maybe the WAP and other thing can WAP will maybe will be a future thing for us.
Yeah. And Dr. Deni Gupta, any comments, sir?
Yeah, tamoxifen 20 milligram or anastrozole 1 milligram is the standard of care, depending on the menopausal status after surgery and RT.
Great. So thank you all the panelists. Thank you organizers.
Thank you. Thank you, Dr.
Thank
Neha.
you.
It was a wonderful session covering almost very vital topics and very aptly moderated. Thank you so much, panelists. Now we quickly proceed towards our next talk by Dr. Richi Khandelwal, gynecologic consultant onco-gynec from all the way from Gurugram. Dr. Richi, are you available? I mean, are you there? over to you, please.
Hello.
Yeah, you're audible now.
Yeah.
So I think you're just out of OT.
Yeah.
Please carry on. Yeah, all yours.
Yeah. Can you see my screen?
Yes, it is visible.
Okay. Okay. Thank you. Is it full screen?
Not yet.
Okay. Just a second. Yeah. No?
No.
It's not full screen?
No, we can see entire laptop screen with. So maybe it is a PDF format, so you can.
It's a PPT format. Can you see the slides?
Technical, yeah, we can see the slides, but it's not full screen. Technical team, can you please help? Anita, get someone.
Ma'am, can we share the slides on your behalf? Can I share you the slides? Can I share the screen now?
But I
with your
need
slides, will that be fine?
But I don't think you have my slides.
And I think it's okay to go. Dr. Ricci, you just magnify a little bit more and then it will be legible. Yeah.
1 second.
No, your slides are not visible anymore.
Yeah, 1 second. Is it
better? Perfect. Yes. No, now it's full screen. It's full screen now.
Yeah, you can see that, right?
Yeah, yes.
So first of all, at the outset, I would like to thank the organizers, especially Dr. Ghanshyam Biswas sir, for making me a part of this wonderful event. And also I can see a lot of participants and most of them are so actively involved as I can see in the chat box. So it's wonderful to see that. And I'll be talking on hereditary breast and ovarian cancer, and hopefully I'll be able to, put across some clear message after the talk. So shall I start?
Yes, please. Yes, please.
Okay.
We all would be grateful if you can just cover it all in time.
I'll try.
Yeah.
So breast cancer is basically the #1 cancer among Indian women. The rates has basically just risen over the years. As you can see in the graph from 1982 to 2012, the rates are just rising and rising. So this is the magnitude of the problem which we are dealing with. Then ovarian cancer, approximately 22,000 new cases are diagnosed each year and 15,500 of these women will die each year. So again, the problem is huge, both for ovarian cancer and breast cancer. So coming to the hereditary cancer syndromes, the genetics of cancer are basically the result of low penetrant polymorphisms or of a single gene disorder inherited in a Mendelian fashion. And it has been seen in the last decade that compelling evidence has accumulated of approximately 5 to 10% of all cancers are hereditary. But syndromes associated with gynecologic malignancies still present significant challenges for all of us. So this is the magnitude of all the cancers, this much is a proportion which is hereditary. Coming to the hereditary gynecological cancers, so there are a range of gynecological cancers which are hereditary, but we'll be focusing on the hereditary breast and ovarian cancer. Apart from that, we have hereditary ovarian cancer, Lynch syndrome, Cowden syndrome, Peutz-Jeghers syndrome, and so on and so forth. So again, focusing on hereditary breast and ovarian cancer, it is basically due to mutations in BRCA1 and BRCA2, and the associated cancers, as we all know, is breast, ovary, melanoma, prostate, pancreatic cancers. So what is the incidence? So gene mutations and the risk of gynecological cancers. So as you can see in the general population, the risk is around 12.4%, but for ovarian cancer, it is 1.3%. But when you have a BRCA mutation, it becomes 50 to 65%, that is BRCA1. And if you have a BRCA1 for ovary, it becomes 40 to 65%. BRCA2 similarly is 40 to 55%. For ovarian cancer, it is 15 to 25%. Other significant cancers is basically with PDEN, which is the Cowden syndrome. Approximately 21 to 50% of cancers, breast cancers, can be seen here. Another one is P53, which is the Lee-Fraumeni syndrome, in which the breast cancer risk is increased. So this is the picture. Basically, hereditary breast and ovarian cancer syndrome are basically caused by BRCA1 and BRCA2, but there are other mutations too. That is like ATM, BRIP1, CDH1, CHEK2, and so on and so forth. But 80 to 90% of hereditary breast and ovarian cancer is due to BRCA1 and BRCA2. So what is the testing criteria? Which individual should be tested? So Breast cancer less than 45 years, all of them should be tested. Breast cancer less than 50 years with an additional breast primary or one close blood relative with breast cancer. And there are certain other criteria which you can see yourself. Breast cancer less than 60 years if it is a triple negative breast cancer at any age with all of these features. And for ovarian cancer, all epithelial ovarian cancer should be tested for BRCA mutations. So what's my risk for cancer? How can you know? So the only answer is genetic testing. So the patient is referred for genetic testing and counseling. Then counseling is done, then blood samples are taken, then you analyze, then you have the test results. So there is pre-test counseling and post-test counseling, which is very, very important as a part of genetic testing. So what is the consent which you have to take and what all you have to include in the consent? Because when the results come, it becomes very difficult for the patient to comprehend those results because they have a lot of implications for the patient and the relatives. So you have to tell the syndrome, the genes to be tested, the associated risks, the possible results and implications, including variants of uncertain significance, the options to assess risk even without testing, implications for family members, what is the accuracy of the test, what is the cost involved, the psychological implications, the genetic discrimination risk, any confidentiality issues, future use of these results, and options and limitations of result-based management, importance of intrafamilial sharing, because most of these patients will not share their reports with their families or their relatives. And you should have a definitely follow-up plan in hand when you are getting these the results. So this is the Angelina effect, a very interesting effect. It was seen when Angelina Jolie got her surgery done. That was around 14th May 2013. The rates of BRCA testing almost increased suddenly. As you can see in the graph, before 14th May, the rates were like this. And after 14th May, there was a sudden jump in testing. So this has been popularly called as the Angelina effect. So what should we test? What should we initially test, the germline or the tumor testing? So it is always recommended to do the tumor test first. If that is positive, then go for germline because that is more cost effective. If you do the germline test first, then the tumor test, then the total cost becomes 24,000 and is not cost effective for that particular patient. So multiple studies have been done with this respect, and they have found that tumor testing first is better as compared to doing the germline testing because the tumor test will detect a higher proportion of tumors and higher proportion of mutations as compared to germline. When you get a positive report in the tumor test, then you can refer that patient on the basis of that pathological variant. That particular variant will be tested in the germline test. So what is important to remember? Does that mean if you have the BRCA gene mutation, you have a cancer or a diagnosis of cancer? No. Just having a gene mutation does not, it just tells you that you are at risk of cancer, but you don't have a cancer or a diagnosis of cancer. So what can be the results from genetic testing? So we have positive, negative, and variants of unknown significance. Positive means that deleterious mutation has been identified. Negative interpretation differs. Basically, if the mutation is known, then it is true negative. If it is unknown, then it becomes uninformative. And variants of unknown significance pose the most difficult challenge for all of us because significance will depend on how variant tracks through the family. Is variant present in people with disease? And we can use software to predict functional significance, and you have to check with lab to see if reported previously. And also you have to follow up these patients because if that VUS, that is variant of uncertain significance, becomes positive, that is you have to follow up in the lab. If it becomes positive over a period of time, then you have to tell that particular patient that now this becomes a significant mutation and you need to have some risk reduction strategies. So what are the benefits and limitations of a genetic test? This applies to all the genetic tests. So potential benefits is clinical intervention may improve outcome. If you already know that you're at risk of something, you might remove that organ and then you can have a cancer-free life. Family members can be identified, positive health behavior can be reinforced, and reduction of uncertainty. You are not uncertain whether you have it or not. Suppose one of your family member has been diagnosed and you are still reluctant to undergo a test because you are uncertain. If you go for a test and if it comes out to be positive, negative, then you're sure that what has to be done in the future. Potential risk is basically adverse psychological reaction, family issues, distress, uncertainty, incomplete penetrance, especially if you get a report of variants of uncertain significance, it becomes difficult. Job discrimination, insurance discrimination, confidentiality issues, and intervention also carries risk because no surgery is without risk. And even So what are the challenges faced in implementing effective genetic counseling in India? So in India, what are the particularly factors which we generally face is basically late presentation. There is a cultural bias, there's lack of training, lack of MDT approach, there are economic issues.
1.5 minutes. Sorry to interrupt. 1.5 minutes.
Yeah. And lack of redressal if BRCA positive. So what are the options for BRCA 1-2 cancer risk reduction? For melanoma and pancreatic cancer, which will not be discussed here. For breast cancer and ovarian cancer, I'll be discussing the risk reduction options. So what is the ideal use? If a female gets tested for ovarian cancer, she's BRCA mutation positive, she's a known case, then we can give her targeted therapy and we can prevent other cancers. And for the relatives, we can do a cascade testing and focus on cancer prevention, but less than 30% of relatives get tested. What is then we can do risk reducing bilateral salpingo-oophorectomy. What is the reduction in ovarian cancer risk by doing that? It is around 80 to 96%. The reduction in overall mortality is 60 to 76%. And what is the reduction in breast cancer risk for premenopausal by removing both the ovaries and tubes? It is also 56% and 46% depending on BRCA1 and BRCA2. And this surgery can be done laparoscopically. What are the recommendations for RSO? You have to do a pelvic USG and CA 125 within 6 months of surgery, appropriate counseling, proper abdominal and pelvic exploration during surgery. You have to take pelvic washings, approximately 50 ml with normal saline. You have to remove the complete fallopian tube at the isthmus. The ligation of the pelvic vessels should be up to the brim, that is 2 centimeter proximal to the ovary. You have to remove all peritoneum around ovaries and fallopian tube. You have to do the CFIM method of pathological discrimination, and you have to refer to genetics and gyne-oncology if possible.
So it's almost time, Dr. Richa. Sorry to interrupt again, but then time is done.
Just a few slides about breast cancer. Screening, if you are positive for BRCA 1-2, then you have to go for a clinical breast examination every 6 to 12 months from age 25 or 10 years before the youngest breast cancer member in the family, along with the contrast enhanced MRI, which has to be done annually from the age of 25 years. If you are BRCA 1 and 2 positive, annual mammography from 30 years. If MRI is not available, then you can go for an ultrasound. Chemo prevention for breast cancers has been discussed in detail earlier as well. So we have limited data, but tamoxifen may be considered because there is a decreased reduction in BRCA2 especially, but less benefit in BRCA1 carriers, decreased risk of contralateral breast cancer as well in observational studies, and adjuvant hormone therapy can be given when indicated irrespective of BRCA status. So this is risk-reducing mastectomy, which is basically simple and total skin-sparing, nipple-sparing mastectomy. And there is no role of doing a sentinel lymph node in such cases because the risk of occult cancer is less than 5%. What should be the timing? It should be as close to the completion of childbearing as possible to provide the greatest lifetime risk reduction. And HRT, the very important role of discussing HRT in these women, because once you've removed the ovaries and the age is around 35-40, then you have to give some kind of HRT to prevent the menopausal symptoms. So HRT is encouraged without contraindications for estrogen and or progesterone replacement. Although there are concerns about a possible increase in breast cancer risk with the use of HRT, but it has been deemed to be safe in women with BRCA1 mutations. So you have to use HRT with the lowest possible dose for the shortest possible time to elevate a woman's symptoms. An increase in breast cancer risk among women taking HRT has not been observed in prospective studies, and a strategy of limiting HRT duration up to the age of 51 years is considered the age of natural menopause almost. So 90% of the women will have natural menopause by 51 years. So you should stop HRT at that time. So conclusion is basically as availability and improvement of clinical genetic testing increases, more and more patients can be detected. You have to motivate your patients for testing to at least reduce disease development in their relatives and family members. Adequate counseling before and after genetic testing is a must, and recommendations regarding screening and management are still evolving. And there is importance of multidisciplinary management in order to achieve improvement of the quality of care and life. Thank you.
Thank you, Dr. Richie. Very well presented and elaborated. I'm sure many take-home messages for the students, new beginners, and of course, for all of us. Thank you. So now we proceed towards our next talk by Dr. Shashank Shekhar Das, who would be talking about evolving
Ma'am, sorry
landscape
to
of...
interrupt. Ma'am, Dr. Shashank Shekhar Das is unavailable right now, so I request you to move on to the next lecture, ma'am.
Sure. So, do we have Dr. Ghanshyam Biswas? Dr. Ghanshyam, you're there? So the next Yeah, sure. Perfect. So Dr. Ghanshyam would talk about emerging landscape of HER2-low, a novel entity in clinical practice, sponsored by AstraZeneca. So all over to you now. Thank you.
Thank you, Romila. So please allow me to share my slides.
Anita?
Yes.
Yeah. Perfect. So full screen and visible.
Thank you.
Thank you.
So we have heard talk of Dr. Anil talking about the importance of HER2-low, and all this happened in 2022 when the standing ovation was given for Dr. Modi, not Mr. Modi. So this is a novel entity in a clinical practice. And really, so this is not a rare, but this is a very common disease. So breast cancer is a heterogeneous disease. And we know it is the #1 cancer since 2020. So there are biomarker tests. So the basic test is IC4, which includes ERPR, HER2-neu, and Ki67. So the incidence and clinical characteristic of breast cancer molecular subtypes, the most common is luminal A, which is almost the 2/3 of the breast cancer population, followed by triple negative, which is around 11%. Then have a luminal B, which is HR positive and HER2 positive, that is around 10%. And the lowest cohort is HER2 positive and HR negative, which is known as a HER2 enriched. So majority of the breast cancer, if you see, are HER2 negative and HR positive, which are supposed to have the best prognosis, slow growing tumors, and usually a low grade. So if you see the molecular subtypes and the prognostic implications, probably the TNBC at this moment has the lowest score or the lowest survival or the worst prognosis. If you see the history of HER2 positive breast cancer therapies and testing, so all this started way back in 1980s when we understand the gene. Then in 1901 to 2000, the first antibody, we know as trastuzumab. Then the next decade, 2000 to 2010, was the first tyrosine kinase inhibitors, and we know that it's lapatinib. And then came the last decade, which was the decade of ADC, and starting from TDM1 and now so on and so forth. Subsequently, in 2007, we started getting an importance of testing this. This is ASCO CAP HER2, which was published initially 2007, then subsequently 2013, and the last one was 2018. So if you see the 2018 last one, so we have already heard this. So HER2 3+ on IHC or HER2 2+ on IHC, and FISH is positive. So these are considered to be HER2 positive, and rest are considered to be HER2 negative. So sometime back, but today's understanding is that except IC0, this the blue one, so that is a HER2 negative, rest IC1+ and IC2+ with the FISH negative is considered as HER2 low. So that's how from the upper one to the, so we have now moved to a HER2 low, which is IC1+ and 2+ with FISH negative. And you see, and 65% of these patients in HER2 low were actually HR positive, and 37%, that is 1/3, is actually a TNBC. So HER2 low, 2/3 are more than 2/3 are HR positive, and almost 1/3 are TNBC. So around 60% of metastatic breast cancer categorized as HER2 negative expresses low level HER2, which is clinically meaningful. So moving from current paradigm to paradigm, future paradigm, you can see more than 50% of patients with breast cancer tumors that expresses low level of HER2, where we have already found out a new targeted drug. So the biology of these HER2 low in subsequent slides you see is different from the IC0s. So luminal molecular subtypes, usually a luminal A, enriched in HR positive, lower Ki67 proliferative index, and you see that these are the patients where neoadjuvant chemotherapy has a very low pathological complete responses. So HER2 IHC0 and low HER2 expressing breast cancers are different clinical entities. So breast cancer expressing low levels of HER2 are more frequently HR positive and luminal and have larger primary tumors and more nodal involvement as compared to IHC0. So this is again from a Lancet that patients with HER2 low positive tumors have improved survival rates compared to that with HER2 0. Stronger effect in patients with HR negative tumors who do not respond to neoadjuvant therapy. So the biological difference can also be narrated that these are tumors with a lesser of grade 3, lower proliferative index and less TP53 mutations. But PIK3 mutations are higher in a low HER2, especially with our HR negative as compared to TNBCs. And also, if you see the HER2 low positive tumors have a reduced PCR rates, in particularly if they are HR positive subgroups, and that has been shown in these slides also. So for those groups, 67% which are HER2 negative and HR positive. So we know that today's before this SONIA trial, so the first line is from moving from hormones to hormones plus CDK4/6. So you can always divide to like the SONIA, so bringing CDK4/6 in the second line. So what's happening in the TNBC? It's all about chemotherapy, and some patients who have germline BRCA, so probably will be receiving a targeted therapy. And capecitabine is a good options. Platinums are always there, and drugs like sacituzumab govitecan can also be used in certain patients who can afford that. And then came the era of understanding of a new category, that is HER2 low, from the French guidelines. So if the patient has received a hormone therapy and moves on to chemotherapy, so the median PFS is 4 to 8 months with an overall survival of 19 to 22 months. But if the patient has received 2 lines of endocrine followed by chemotherapy, so there is a reduction in median overall survival and a PFS. So up to 40% of advanced HR positive HER2 negative breast cancer respond to first line treatment, but eventually they will all have an endocrine resistance, and then we start asking for some options. So these are TNBCs. You can see first line chemotherapy in a TNBC, median PFS of 3 to 11 months, OS of 22 months. First line IOs, we have already talked heard from Dr. Uma. So the median PFS of 7 to 10 months, overall median overs are not reached. Second line chemotherapy drops down to 1.5 to 10 months, overall survival significant drop, 4 to 14 months. And then if you want to use sacituzumab, median PFS of 5.6 months and overall survival of 12 months. But this NSCBP trial showed that anti-HER2 monoclonal antibodies like trastuzumab, when you're combining with chemotherapy, has found to be a limited activity in a HER2 low breast cancers. So HER2 1 plus or 2 plus with FISH negative. So trastuzumab is not doing any wonders like those of HER2 3 plus. So this is a phase 2 study of a dose finding pertuzumab 420 versus 1050. Again, so no much benefit in a HER2 negative. Again, another phase 2 trial of anti-HER2 margetuximab, not doing anything useful for a low HER2 subset. But this is another ADCs. So we are not talking about trastuzumab deruxtecan. So this is another ADC like the trastuzumab duocarmazine in HER2 low breast cancers in HR positive and triple negative. You can see in HR positive, the upper one, you can see a waterfall of 28% of overall response rate, whereas in TNBC, 40% of response rate. And these are patients who have been exposed to trastuzumab, pertuzumab, and even there are patients who have been exposed to TDX. So now we come to TDX, trastuzumab deruxtecan, so which is so much talked about since 2022 ASCO. So the Destiny Breast 04, now there are n number of Destiny trials. So this, we understand that ADCs are difficult, and good part is that India has already first ADCs like the Uzvira from Zydus. Now you can see, so these ADCs have 8:1 drug to antibodies. We have a cleavable linker, and the highly potent topoisomerase 1 inhibitor is the payload. And all these are happening because of a bystander effect, the rationale for targeting HER2 low MBCs. So this was the phase 3 studies, which included HER2 low, all unresectable patients, 1 or 2 prior lines of chemotherapy. If they were hormone positive, then endocrine refractory. 2:1, 2 in favor of TDX, 5.4 milligram per kg every 3 weekly versus treatment of physician's choice. You talk about any chemotherapy. The primary endpoint was PFS by BCI, PSR, and all other secondary endpoints. So exploratory analysis. So prior CDK4/6, we know that last 8 years, so most of our patients of HR positive will be on some of the other CDK4/6. Disease burden, low, 0 to 2 or high, rapid progressions, and the HER2 status, IHC 1 plus versus IHC 2 plus with IHC negative, number of prior lines of chemotherapy, 1 or 2, then age, and there were a handful of patients with CNS metastasis, and also because anthracyclines were used or not. So these were demographic, so almost balanced. You can see 1/3 of the patients were also from Asia, and almost 60% patients were HR2 1 plus. And all these patients had a good performance status, and brain metastasis, as I said, in a handful percent, 5 to 6%. Almost 90% have visceral metastasis, liver being the commonest, followed by lung. If you come to the lines of systemic therapy, almost more than equal to 3 lines of systemic therapy, which includes hormones and chemotherapy and targeted therapies, almost in 2/3 of the patients. If I talk about lines of chemotherapy, almost in 2 lines, almost 1/3 of the patients had 2 lines. Otherwise, most of these patients have at least 1 lines of therapy. Coming to targeted therapy, CDK4/6, almost in 70% of the patients. So now coming to PFS in HR positive and all patients. So all patients means HR positive and HR negative. So you can see in the test arm, that is trastuzumab deruxtecan, so the median PFS was 10.1 versus 5.4 with a hazard ratio of 0.51, that 49% reduction in deaths. So this is PFS minded. On the other hand, if you combine all this population, HR positive and HR negative, again, a beautiful PFS of 10 months versus 5 months with a hazard ratio of 0.5. So now see the overall survival. So why you are talking so much of this drug? So because even in the hormone positive, you can see deruxtecan arm, 24 months of median OS versus 17 months in the chemotherapy arm with the hazards of 0.64, though the curves are almost touching at 26, 28 months. In the all population group, again, 24 months versus 16 months. You can see, so every patients are benefiting, not only HR positive, even a TNBC patient. So explain endpoints of PFS and OS in a triple negative group. So what's happening in the triple negative? Oh, this drug is wonderful. You can see, so 8.5 months versus 2.9 months. So we understand, so this is the bad subset of patients you see in clinical practice. So progression-free survival, huge difference. OS, again, 18 versus 8.3. The curves are 24 months, curves are absolutely separate. So overall safety, since we are talking about a ADC and a new drug, so median treatment duration on TDX arm was 8.2. You can see ranges. There are patients who receive up to 23.
2 minutes. Sorry to interrupt. 2 minutes.
And in the chemotherapy arm, only 3.5 months exposure. The common reason for discontinuation was ILD and pneumonitis on 8.2%, and dose reduction was because in 5% have nausea and fatigue, and there were deaths in both the arm, 3.8 in the TDX arm versus 4.7 in the chemotherapy. Most of these are because of a disease progression. So the adverse event of special interest, so ILD and pneumonitis in the ADC arm was almost 12%, and grade 3 was 1.3, but no grade 4, and ejection fraction decreased was 4.3% in the TDX arm, and the cardiac failure was not significant. So the Destiny Breast 04 establishes deruxtecan as the new standard of care in HER2 low, HR positive, HER2 negative metastatic breast cancers, because we have seen a huge PFS and an OS benefit as compared to the treatment of physician choice. That's how the FDA approves this drug as in a HER2 low setting. So coming to now sacituzumab govitecan, though this came as a phase 3 ascent, so here the drug into antibody ratio is 7.6:1 and SN38 is the payload. So this was basically showing a benefit in a more than 1 or 2 lines of patients in a triple negative. So 4.8 versus 1.7 median PFS, overall survival 11.8 versus 7 months. So this was for a TNBC. And this accent actually had a retrospective analysis, and they found out there are patients in the HER2 low also. And the subsequent progression free in the HER2 low, you can see. So when this retrospective analysis was done from this ascent, IC0 versus HER2 low, you can see a huge PFS benefit even in the HER2 low. Overall survival again.
Sorry, sir, time is up. But then,
right.
Yeah.
So this author concluded that sacituzumab govitecan is also can be used in somebody who has a HER2 low, and that's also been established in the TROPiC-2 in this ASCO 2020. So there are other targets also. So last slide, more effective treatment options are needed in patients with advanced HER2 negative breast cancers. Up to 55% of breast cancers have HER2, so low HER2. So this is a major chunk. So novel HER2 targeted ADCs have shown encouraging responses, but optimizing diagnostic process to establish HER2 low, that's the whole key take. Thank you so much. Thank you, Romila.
Thank you so much, sir. I would not let you go now because we come to an end of the breast session and we have to start the lung. And I believe you would be the quiz master to start off the lung session.
Please allow me to share the slides.
Anita, can you please help? Yeah, it's visible now, sir. Are you being able to access? Full screen now. Yeah, perfect.
So get ready for the quiz.
So 30 seconds timer.
Yes.
I think someone is unmuted.
So team, are you ready?
Team is ready, but then I guess somebody has.
So, sir, can we share the slide from our end so that the timer will also be there?
Please
Will it
go
be
ahead.
fine? Yeah, sure.
Yeah, go ahead. No problem.
Yeah.
Ready, steady, go. So first question. So ALK positive NSCLCs, choose the wrong one. So these are the 5 anti-ALK agents and the dose mentioned. So you have to choose the wrong one. The first, please start the time, no? So crizotinib 250 milligram BD dose, ceritinib 450 milligram or 750, alectinib is 150 milligram 6, so that makes 450 BD. Brigatinib 180 milligrams, so brigatinib comes as a 30, 90 and 180. Lorlatinib comes as a 25 and 100. I think many of them have rightly answered. So go to the next slide. So the answer is there. So crizotinib 250 milligram BD is the right dose, and ceritinib, so either you can give 450 or 750. So the initial trial shows 750. So now we have resorted to 450. It comes as a 150 milligram. Alectinib, it comes as a 150 milligram. So 600 milligram BD, that makes 1200. So it means 8 capsules, not 6 capsules. So brigatinib comes as a 30, 90 and 180. So for first few weeks or few days, you can start with the 90 and then increase the dose. Lorlatinib 100 milligram. So if there are toxicity, then probably you need to dose. Second question. So the lung cancer mutations. So we know that with lung cancer mutation, we have been talking for a decade or more than a decade now on advanced EGFR mutations. But this question is regarding early lung cancers, because we know the ADURA trial also. Choose the right answer. So early versus advanced EGFR mutations, the incidence. So early 15% versus 30% in the advanced, 20 versus 40, 10 versus 30, 30 versus 30. So that means you have to answer which is the right one. So EGFR mutations in resectable lung cancer versus unresectable lung cancer, which is the right one. So next. So here is the slide. So you can see, So EGFR mutations in early lung cancer is around 15%, whereas in a metastatic lung cancer it is around 30%. So answer 1 is right, 15 versus 30. Next. Third question, US FDA approvals for NSCLC during the COVID pandemic, May 2020 to May 2021. So almost in 12 months. How many approvals? So this was a thick of COVID, right? So when most of the normal population was sitting at home, when probably the frontline workers were at office or at hospital seeing patients, cancer along with COVID. So the research never stopped, the science never stopped. In this COVID pandemic of 12 months, so why the timer is not on? So in these 12 months, how many approvals were given by the FDA? So is it 5, is it 10, is it less than 5, it is less than 10? I think many have been answering right. Good. That's the spirit. Please go to the answer. So US FDA approvals from NSCLC COVID pandemic for May 2020 to 2021. You can see capmatinib for MED-exon 14, sulfacetinib for red fusion, atezolizumab for first line, nivo-EP, brigatinib for ALK, nivo-EP for limited chemotherapy, that is 9-LA regimen. Then the relay for ramucirumab, alutinib for exon 19 and exon 21. Then perlutinib for red fusion, then abimantab for exon 20 insertion. And the last was sotorasib for KRAS G12. Next. So we come to the penultimate question. MET exon 14, timer please, is the most commonly reported MET mutations observed in 3 to 4% of patients with NSCLC. Commonly associated with which histology? Squamous, adenosquamous, sarcomatoid, adenocarcinoma. No right answer yet. No right answer yet. That's the hint. Right answer now. There are 2 right answers. Wow, get to the answers. So, highest frequency in NSCLC with sarcomatoid histology. So, MET exon 14 is an independent oncogenic driver. So, the right answer is a sarcomatoid. So, that was choice number 3. Next. The last question for the day, last question for this IAO webinar series Oncology Update 2023. Thank you for joining. So the last is adjuvant duration. Choose the wrong one. So how long you are going to give it? Adura is for osimertinib in resectable lung cancers. 3 years. Olympia, olaparib for 2 years. Solo 1, olaparib for 2 years. Extract sunitinib. So those who have attended yesterday, Dr. Amol Akhade, so 1 year. So which is the wrong one? Right. So Adura osimertinib 3 years. So the survival data has been presented this ASCO 2023. Olympia. So olaparib. So you can see. So 1 year. So not 2 years. So that's the right answer is 2. Olympia is 1 year duration of olaparib in a residual disease of TNBC or HR positive. So not 2 years. Thank you. Over to Romila for the next session.
Sir, actually, thank you so much for the quiz session, sir. Dr. Romila ma'am is facing some network issues, so we will be moving on to our next session now, sir. Thank you so much, sir.
What happened to the Novartis session? Dr. Sasanka Sekhar Das?
Sir was unable to join, sir, so we are like reaching him. So as of now, we'll move on to the next one, sir.
Okay, so then we move to the lung cancer session.
Yeah, sure, sir.
So we move to the lung cancer session. ASCO updates in lung cancer. So none other than Dr. Chetan Deshmukh, my good friend from Pune. So we were together in Mumbai during our DM days. Over to Chetan da.
Yeah, thank you, Ghanshyam. And I know it has been a little late. Can you please present my slides at your end?
Sure, sir. We are sharing it.
Excellent. Yeah. So there was a lot of data presented at ASCO. I have picked up a few slides, few studies which I felt were relevant and are probably exciting. So may I have the first slide?
Sir, is the screen visible?
Yes.
Yeah, thank you. Thank you, sir.
Just make it full screen and move it to the first slide. Yeah. Can you please make it full screen?
We are doing it, sir. Just a second, just a moment.
Okay. Yeah, so this is the Tropion study, datopotamab deruxtecan plus pembrolizumab with or without platinum chemotherapy in advanced non-small cell lung cancer. Dato-DXd is a new antibody drug conjugate composed of a TROP-directed monoclonal antibody, which is linked to a potent cytotoxic payload. So this was tried as a monotherapy, 6 milligram per kilogram, which showed some encouraging anti-tumor activity. The overall response rate was 28% and a median duration of response of 10.5 months in patients who were very heavily pre-treated lung cancers. And that is why this study has been brought, the drug has been brought up in combination with immunotherapy as well as conventional chemotherapy. So this study, Tropion Lung 2 study, had advanced lung cancer patients, and quite a few of these were pre-treated. There were 6 cohorts, out of which 2 cohort 1 and cohort 2 were doublets of datopotamab deruxtecan plus pembrolizumab, and the cohort number 3 to 6 were triplets of dato-DXd, pembrolizumab, and either cisplatin or carboplatin. The primary objective was safety and tolerability, and the secondary objectives were efficacy, pharmacokinetics, and anti-drug antibodies. The baseline characteristics were reasonably well matched in both the groups. The majority of them were adenocarcinomas. Almost 20% of patients had brain metastasis. PD-L1 expression was variable, but a significant population, 20-25% people had a PD-L1 expression of more than 50s. 20-25% patients had also received prior immunotherapy. So immunotherapy was previously given. So in spite of that, immunotherapy was re-challenged in this study. The response rate, the confirmed plus pending overall response rate in the doublet was 23 versus 35 in the triplet arm. And this was in all patients. In the first line patients, it was not very different, 17 and 30. So whether you use it in the front line or second line, it didn't really matter. Most of these patients had a partial response. And amongst all patients, the disease control rate was 84 and 87% respectively in the doublet and triplet arm. So essentially a very powerful drug. Only thing seems to be, we need to know how best to use it. The waterfall plot again shows that a fair amount of patients had some kind of tumor response, which is again evident by the DCR rate. Not a very safe drug, has its own share of problems. Stomatitis seems to be the most treatment emergent adverse events. Nausea, anemia, fatigue, and hematologic toxicity was more. And as expected, it was more frequently observed with triplet therapy than with doublet therapy. There were no grade 5 adverse events, and there were no grade 4 or grade 5 interstitial lung disease or pneumonitis events, which we have seen with trastuzumab deruxtecan. So impressive overall response. Toxicity, we'll probably learn to manage it. Maybe a robust biomarker will help us select our patients better, and a combination with lesser toxic partners may help reduce toxicity. The second study, which I found interesting, was a primary endpoint analysis of the Scarlet study, a single-arm phase 2 study of sotorasib plus carboplatin pemetrexate in advanced non-squamous non-small cell lung cancer patients with a KRAS G12C mutation. We know that KRAS G12C is now a druggable target in advanced non-squamous lung cancer, though the incidence is lower in the Asian population compared to the Caucasian population. Nevertheless, we do see a lot of patients now that we are doing sequencing quite routinely. The standard treatment for frontline is usually either an immune checkpoint inhibitor plus or minus a platinum doublet, sotorasib and or cytotoxic chemotherapy. So far, we've used.
Sir, sorry to interrupt, sir. Can we change the slides? Please let me know when to change the slides. So accordingly, we'll be operating it here, sir.
Yeah. So go on. You need to go on a little more fast. We've already gone to the second abstract.
Yeah, sure, sir.
Go on. Yeah, one slide before, 2 slides before.
Yeah, this is the one, sir. Yeah, thank you.
This is okay. Yeah. So just keep track. So as I speak, I'll try to remind you.
Sure.
The Scarlet study has used sotorasib in the upfront setting, the advanced squamous, non-squamous lung cancer, G12C mutation, who are essentially naive for cytotoxic chemotherapy and any KRAS-directed therapy with good performance status. They allowed asymptomatic CNS mets. These patients received sotorasib 960 milligrams plus PEM-carbo, the standard combination for non-squamous carcinoma, and then patients who responded continued on sotorasib plus pemetrexate maintenance. The primary endpoint was overall response rate by a blinded independent central review. The secondary endpoints were disease control rate, progression-free survival, duration of response, overall survival, and of course, adverse events had to be noted. Next slide. It's a small study, only 30 patients, because it's not a very common mutation. Nevertheless, had a mixture of patients, predominantly male patients, and most of these patients were ex-smokers. Adenocarcinoma was the highest, the most common histological type, and a split mix of CNS metastasis. Some of these patients were also pre-treated with immune checkpoint inhibitor. This is particular, the waterfall plot really looks impressive. The blue bars represent partial response, and almost most of these patients, 24 out of 30 patients, showed some kind of response. So overall response rate is 88.9%. Almost 90% of patients have responded. The median progression-free survival was 5.7 months with a 6-month PFS probability of 49.6 months. This was more or less the same either by the BICR or the investigator-assessed PFS. Next slide. Next slide. Yeah, but not a very easy to use drug. Lots of problems: anemia, thrombocytopenia, neutropenia, diarrhea, malaise, constipation, transaminitis. So all in all, quite a troublesome drug. But and remember, this table shows the treatment related adverse events which were more than 15% or those who were severe. Next slide. Yeah, so it's a small study in a very niche subset of patients, which has an impressive overall response rate, but it comes at a cost of significant toxicity. This space needs to be watched. We need to see more about, hear more about this combination, and probably get some more survival data to find out how things are moving. Next slide. So this was another most talked about study in the even in the social media and at various meetings. The overall survival analysis from ADAURA trial of adjuvant osimertinib in patients with resected EGFR mutated stage 1B to 3A non-small cell lung cancer. Next slide. So these were patients who had undergone a complete resection for their lung cancers, stage 1B to 3A, with or without adjuvant chemotherapy. These patients had to have an EGFR mutation, either a del19 or L858R mutation. and patient had to have a complete resection with negative margins, and adjuvant chemotherapy was allowed. So if a patient had completed adjuvant chemotherapy, then up to 26 weeks from after surgery was allowed. These patients with they were then randomized to osimertinib 80 milligram once a day versus placebo. It was a 1:1 randomization, and the planned treatment duration was 3 years. And treatment had to be continued till disease recurrence, treatment completion, or discontinuation criteria were met. The primary endpoint was disease-free survival. Next slide. Earlier, the earlier analysis was presented in NEJM 2020, and now the updated DFS analysis has been published. Both have shown quite an impressive benefit as far as disease-free survival is concerned. It is highly statistically significant, and both in the primary stage, that is stage 2, stage 3A, or even in stage 1B population with a fairly tolerable safety profile. Next slide. The overall survival was again significantly better with osimertinib compared to placebo, and the hazard ratio for overall survival is 0.49. So definitely looks impressive, but there were some issues with the study as well. Next slide. So for stage 1B, the number looks 94 to 88, stage 2 85 to 78. The maximum benefit was seen when it was used in stage 3A, where 85% patients on the osimertinib arm were surviving compared to 67% in the placebo group. So patients with or without adjuvant chemotherapy did not matter. Even if you gave adjuvant chemotherapy, it still worked. Without adjuvant chemotherapy also, it continued to work. The problem was with subsequent treatment, that not all those patients who progressed after the on the placebo arm, those who progressed should have been offered osimertinib, but not all of them were offered osimertinib, and this has been one of the talking points on the criticism of this study. Nevertheless, the drug is simple. The drug is, we have used osimertinib in metastatic lung cancer. We know that the side effect profile is reasonably manageable. Most of these patients do not have any major issues. So probably it's an impressive benefit as far as DFS is concerned. The primary analysis at least looks very impressive. The OS benefit also has been shown to be statistically significant. A hazard ratio of 0.49 is something which cannot ignore. And it's probably the first global phase 3 study to show a benefit of PFS and OS in using adjuvant osimertinib. So am I impressed with this study? Yes, definitely. Survival figures are impressive, though there were some questions about the study design. We probably need to look at it again. Osimertinib was not offered to all on progression. My concern is it is applicable to very few patients. Operable. May I have the next slide, the last slide? One more. Yeah. So it's applicable to very few patients because we see very few operable lung cancers. Lung cancer screening is not regularly practiced in our society. That's why we won't have too many takers for adjuvant therapy, especially this kind of therapy in our practice. That is my only concern. Next slide. I think this is my last study, a randomized phase 3 study of chemotherapy versus chemotherapy plus pembrolizumab in patients with treatment naive pleural mesothelioma, a Canadian trial. Next slide. We have all treated pleural mesothelioma. It usually presents with a very advanced disease, and pemetrexed has been a blessing that for a disease which was not amenable to any treatment, we have been able to give some kind of response and survival to most of these patients who have an advanced disease. There has been some benefit with a combination of nivo-ipi. The combination showed improved overall survival compared to platinum and pemetrexed, and the largest effect was seen in the non-epithelioid subtype, but most of these patients developed some kind of toxicity, and 30% had grade 3 or more treatment-related toxicity. So this study was designed to have addition of pembrolizumab as a single agent to the combination of platinum and pemetrexed. Next slide. A simple design, chemotherapy naive patients with pleural mesothelioma were randomized 1:1 into platinum pemetrexed versus platinum pemetrexed plus pembrolizumab. Pembrolizumab was given for 2 years and platinum pemetrexed in the usual 3-weekly cycle. Next slide. Patients who had pembrolizumab added to their combination had a better response. The complete, in fact, some of them had a complete response, and the partial response was significantly better in patients who received pembrolizumab along with their standard chemotherapy. Stable disease was again slightly lower in the pembro arm, but overall the regime seems to be helping patients with mesothelioma. Next slide. Overall survival slightly better, not terribly. The benefit numerically is probably just about the median OS benefit. Without pembro is 16.13 versus 17.28. So not a very great benefit. Probably over a period of time, this benefit will, the tail end will continue to show some benefit. So addition of pembrolizumab to standard platinum pemetrexed showed good symptomatic improvement, significant improvement in survival as well. The important aspect is it gives a good partial response. So these patients.
Sorry to interrupt, sir. Your time is almost over.
Yeah, just two lines. So this patient, these patients had good response. So these patients with a improvement in the response will also improve their symptomatology and quality of life. Thank you.
And thank you, Chetan, for covering the ASCO update. Now we move to the panel discussion moderation by Dr. Prasad, good friend, TMH alumni. So he will be discussing on the neoadjuvant IO and adjuvant IO therapy in early lung cancer. So, and that's have been a hot topic in all debates in each meeting these days. So I'll just inform the Prasad that Dr. Chiraranjan Khadenga and Dr. Prasad Mahapatra has not joined. Otherwise, our good old Tata friends, George Arvind from Surgical Oncology, Dr. Sanjeev Mishra, again, a Tata colleague and colleague from Odisha. So he's a radiation oncologist. Amit Kumar, medical oncologist. Saurabh Mishra, Jogmaya Patnaik, and also Dr. Rupanita, pathologist. So all are there. Over to you, Prasad.
Yeah, thanks, sir. Good evening.
Yes.
And it's great to have a session where we are almost, it's almost as if the hostel room of Tata Hospital, where across the room we had Dr. Arvind and then George and Vishwas and Chetan. So, and Sachin also is there in the panel, I can see. So without much time, I think we are already running late. I'll try to share the screen. Is the screen visible?
Yes, yes, Prasad. So you're visible, your slides are there, you're audible.
Right. So we have 25 minutes. We were told that we will have 9 panelists. Now we have 7. So maybe we will try to cut some of those questions which I had already planned with the panelists in mind, actually. So this question is irrelevant now because the pulmonologist is not there. So I can ask this question to probably Dr. Arvind. Do you see that any early stage lung cancer will actually go to a medical oncologist first? But because we are going to talk about neoadjuvant and adjuvant therapy, have you ever seen an early stage lung cancer which has been referred to you from a medical oncologist?
No, generally it doesn't happen, but I guess like these crosstalks have to happen more frequently in the coming years to come, because I think neoadjuvant therapies is coming in a big way. So ultimately, I guess, you know, at a time, maybe medical oncologists will first see these patients. But for now, I guess, at least in our institution, I think early lung cancers, so most of them surgeons see first. And of course, subsequently, everything is discussed in an MDT.
Yeah. Dr. Jogmaya, since I can see you in the screen, have you ever seen an early stage lung cancer yourself first and then referred to a surgeon, or it is?
Sir, early stage lung cancer is actually very rare. I have not seen early stage lung cancer patients. Mostly in my practice, the patients are locally advanced or they are
Right. So, George, you're there? George is not there, is it? I saw him in the list actually.
Yeah, sir. Unfortunately, I think he had some technical difficulty. He had to exit the meeting.
No problem.
Unavailable
So,
right now.
Arvind, Dr. Arvind, I'd like to ask you this question also.
Yeah.
So, what percent of your patients after surgery, because I kept it for George because he had some slides which I have always seen about what percent of the patients actually from the total patients who come to thoracic oncology finally undergo surgery and all that.
Right.
But what percentage of them after surgery go for any adjuvant therapy? Because we are now talking about neoadjuvant, adjuvant immunotherapy, and you just heard Chetan talking about the ADAURA study. So what percent of patients go for any adjuvant therapy these days?
Generally around 5% of the patients in all get operated.
Right.
And very few of them would actually be early. So a lot of them would be stage 2 and stage 3 as well. And so barring, of course, stage 1A, some high risk stage 1B onwards, and stage 2 and stage 3, all of them would get. So I think a significant proportion of the patients who we operate would be referred for adjuvant therapy.
So very rightly said. And barring stage 1A, so let us ask Dr. Upanita, who is our pathologist. Can you just enumerate the high risk features which Dr. Arvind was just mentioning now?
Yes, sir. So actually for stage 1, if then again we can divide into whether we are going for a core biopsy or the post surgery. In a core biopsy, if we are seeing any solid or micropapillary pattern, those are again a high risk. Apart from that, post surgery, if we are seeing any pleural involvement or there is a lymphovascular involvement or a margin positivity, but not just margin positivity. Suppose a patient has undergone a segmentectomy, then it has to be a 2-centimeter margin at least. A new concept has come, that is STAS, that is space sprayed along the alveolar spaces. So that is something we are seeing, the micropapillary or solid clusters of tumor cells beyond the advancing age of the tumor. So that is again is a risk factor for the patient.
Right, rightly said. So, Dr. Arvind, you talked about the stage 1B indication for chemotherapy or adjuvant therapy. There is one soft indication like increased SUV on PET. Do you actually consider that?
Not really, although we know that these prognostically they may not do that well, but generally our high risk factors would involve visceral pleural involvement, vascular invasion, lymphatic invasion, or as was said by our pathologist colleague, micropapillary pattern and some neuroendocrine tumors.
Sure. So the LACE meta-analysis is what we base our discussion on, and there was a 5.4% improvement in outcome in stage 2-3. There was no doubt about that. From there, we get this data of the adjuvant immunotherapy, which is one of the points of discussion for us today. So adjuvant immunotherapy data is from these two trials, IMpower and the Keynote study. These are both large adjuvant studies which have be kept DFS as their endpoint, and the overall survival data is immature in both the studies. Atiso mostly works in PDL1 more than 1%. Pembro data is regardless of the PDL1. Both are data are immature in terms of overall survival. The DFS benefit was there in both the studies, which is significant in both the studies. So with this in background, again, Dr. Arvind, because George is not there, I like to ask you this question.
Sure.
So, will you? There is no overall survival. When we talk about adjuvant therapy, our gold standard, we again keep on saying, where is the overall survival advantage? Will you wait for that, or will you support a medical oncology colleague in the MDT who will say that we will give adjuvant immunotherapy with the approved drugs? And also your major criticism of this data.
Yeah, as you rightly said, of course, we still await the overall survival data. But having said that, I think there is definitely a DFS benefit. Of course, I would encourage a dialogue of the patient in the MDT, because generally stage 2 and stage 3, about 50 to 60% of these patients would eventually recur or die. So there is a gap in our treatment, and we really need to do better with that. Somehow for me, the neoadjuvant way seems to be a little more impressive, but then supposing we did land up operating them first, and if there are some high risk features, especially stage 2, stage 3, I think this benefit should be offered to the patients, and even as we sort of await the overall survival results. So I'm not against this concept. I would sort of have a discussion with the patient, and ultimately the risk benefit ratio. Of course, there are issues of toxicity, there were issues with costs. I'm sure all these things would be a part of the discussion with the patient.
Sure. Well said. And I think you rightly pointed out that there is a long way to go in terms of the stage 2, stage 3 lung cancer post chemotherapy, or even with the IO data. I think definitely any treatment which actually improves outcome is welcome here. So we'll go to our medical oncologist team, Dr. Amit, Dr. Saurav Mishra, and Dr. Jogmaya. So Dr. Amit, do you speak about adjuvant immunotherapy in patients post-surgery? If yes, then what is your plan? What is your practice?
Surely we offer the patient and let them know what are the treatment options are there for adjuvant intent. Basically, they have both. This drug has got the FDA approval, but they are really the limitations. The caveat with Atizo is it is more beneficial in those with PD-L1 more than 50%, and those with Pembro. But with Pembro, that things are something different. Even in more than 50% PD-L1, it hasn't shown much benefit as compared to other. So though they have shown a DFS benefit, OS is still immature, but we have to make a shared decision with the patient. We have to offer them that these are the options available. And if, to be frank, in my practice, if the patient is more high PD-L1 positive, I will recommend them more. My counseling will be more in favor of immunotherapy. If not, then I may omit also.
Good point. So, Dr. Saurav, to put this question in a different form, what is your major criticism about this adjuvant study data to consider it into practice? Like never smokers, mutation positive patients, PD-L1 less than 50%, they did not have the benefit, anything like that, or any specific point you want to make about your critique about this data?
So basically, one thing is that there have been 3 settings in which they have used these adjuvants.
Right.
One is in the peri-operative setting, in which they have given pre-op, then post-operative again they have continued. Then there is a new adjuvant setting, and then there is one adjuvant setting.
Right.
So if we see all these 3 settings, so exactly the benefits of this peri-operative, if you've given pre-op, then continuing after.
We will come to that later. This point is about the adjuvant data, about these 2 data, which is the basis of the adjuvant immunotherapy.
Most, if at all, the major criticism here would be that we are still awaiting the overall survival data.
Right.
We are still not having that impressive data, but I think what is important is that whatever data we have, it is clinically meaningful. So for me, the major criticism would be that these are patients who are not having a long-term survival data, and we need to wait for that.
So overall survival, the holy grail was is one of your major criticism taken. So Dr. Jogmaya, I want to ask you a different type of twist to this question, because after the data in head and neck about low-dose immunotherapy seems to be the go-to option for many of us in many cancers, actually, we are giving. So do you think that a low-dose immunotherapy, suppose a patient has got a PD-L1 score of 70%. In the adjuvant setting, the patient is with you and the patient cannot afford the high-dose immunotherapy. Will you even think about giving low-dose immunotherapy? Do you think it will work in the adjuvant setting?
Sir, my answer is yes. There are 2 reasons for that. One is that neoadjuvant, adjuvant, or perioperative immunotherapy, whatever way we use it, at least in all trials, it is at least 1 year of immunotherapy. That causes at least a lot of financial toxicity to the patients. Second point is that low-dose immunotherapy, as you have shared, it has shown benefit in head and neck cancer. Even in lung cancer, there are data for nivolumab and even pembrolizumab. Nivolumab 20 milligram to 100 milligram has been used in advanced lung cancer in low dose. Second is pembrolizumab also has been used as a 100 milligram dose rather than 200 milligram dose. It is in advanced, but it is in advanced. Nowadays in clinical practice also we use this. Like we cannot find any 100% data for that. We use it. If the patient cannot afford, then we use and lower the dose.
Consider is what
So
you
I
feel.
feel it is better to give a lower dose rather than omitting it.
Got it. So we may see a data coming from Tata Hospital with the way the thoracic and the head and neck team is functioning there. We will be churning out some paper on adjuvant immunotherapy, low dose is what I'm assuming. So I'll come to Dr. Sanjeev because Dr. Chiranjan is not there. What do you, where is the role of adjuvant radiation in resected lung cancer these days? And do you think that adjuvant immunotherapy, since we are talking about immunotherapy adjuvant, do you think that radiation, as a radiation, we know the data of adjuvant, the data of durvalumab we know. So do you think with radiation will be a good option for some patients, at least in a trial setting, in the adjuvant setting?
Yes, Dr. Prasad. It's a very nice question. Basically, if you give radiation, we give usually in margin positive post-operatively. Otherwise, we never give radiation in lung cancer post-operatively.
Right.
Post-operatively, you are talking about in early lung cancer about adjuvant immunotherapy or pre-op immunotherapy. But have you ever compared both the arm like adjuvant chemotherapy versus only adjuvant immunotherapy? Do you have any data? Number one. Number two is for adjuvant radiotherapy like durvalumab data concurrent versus this one. So what we found in the trial, in a phase 1 trial, is that if you are giving radiotherapy along with immunotherapy, toxicity is very high. I was looking into that that paper. They have given, I think, 45-day radiation followed by pembrolizumab. So if you compare the durvalumab data, that radiation dose was 70 gray with post CTRT durvalumab, and this was 45 gray followed by pembrolizumab, with pembrolizumab followed by adjuvant pembrolizumab. So when you talk about radiation, no, you need to see the dose, you need to see the contour, how much you are treating, how much volume you are covering with radiation. Because if you look at the durvalumab data in that paper, they have contoured a very small volume. They have not even done a PET CT. They have done a CT and gross nodal volume in the mediastinum with 1 centimeter margin from the CT only. So they have not even treated the whole of the mediastinum in stage 3. But in the early stage data, they have given 45 gray. I didn't find anything how much volume they have treated, but the toxicity was there. I think there are 2 to grade 5 toxicity. That's why they stopped it. Whatever I came to know. Otherwise, there is no role in radiation as far as I know. My knowledge is concerned.
Thanks for this. So we move on to the new adjuvant session now. So the neoadjuvant chemotherapy is practiced too much in lung cancer, but the data is all from underpowered studies. It is more of a logistics or as a bridge to surgery. I think Dr. Arvind will agree with me. Dr. Arvind, what do you say? Do you think that neoadjuvant chemotherapy data is based on large volume of data which we have, or it is just a matter of convenience? And there are so many reasons like single station mediastinal node, superior sulcus tumor, chest wall involved with N1 node, but most commonly it is given due to logistic reason. If I say that, will you agree with me?
Yeah, we do have data to suggest that, the chemotherapy has to be given, whether you give it pre-operatively or post-operatively, benefit is around 5%. So either way, so I think that you should be good. But what definitely is there is that when compared to surgery, I think pre-operative or perioperative chemotherapy seems to do better. So that's where and you have some meta-analysis, of course, when you don't have real robust data to support this benefit of around 5%.
Absolutely. So with a dicey wicket of chemotherapy itself in neoadjuvant setting, we have this amazing trial which looked at nivolumab, the Checkmate 816 trial, which gave a PAT CR of 24% versus 2.2%. I mean, amazing data. So I want to ask Dr. Arvind, will you consider PAT CR as a worthwhile endpoint in lung cancer with neoadjuvant therapy, and with an EFS benefit and PAT CR, will you say that, and this treatment, the only side effect is the cost, take it like that? And you think that this is interesting data worth exploring, with especially in the situation that the cost may come down if you give a low dose immunotherapy. Low dose immunotherapy, it seems to be working almost similar to the given dose usually.
No, absolutely. I think this is exciting data. And with regards to the endpoints, I think there have been some studies earlier also to suggest that both PathCR and maximum pathological response, as they call, can be reasonable endpoints for event-free survival. So I think there has been also a systematic review and meta-analysis published a couple of years back to say that PathCR, especially PathCR, and to a lesser extent, maximum pathological responses. So I'm pretty excited with this particular data with event-free survival. Although again, the overall survival results are immature and yet to sort of come.
Sure. So medical oncologists have a habit of adding and getting into the system somehow actually. So we started with less than adequate data, but still chemotherapy is given as neoadjuvant. And then this PathCR data of immunotherapy, and now this trial. These two trials are from the ASCO this year. Chetan did not present this trial because I don't think he felt it is as important as the ADAURA study. So pembrolizumab, or he wanted to give it for the panel discussion on immunotherapy. So this is pembrolizumab chemotherapy versus placebo chemotherapy as neoadjuvant. That's a keynote study. Again, the primary endpoint is EFS and resectable stage 2, 3A or 3B. And the investigators concluded that this is a significant improvement in EFS. The EFS is not reached in the pembro arm, 17 months with the placebo. Overall survival data is not significant. And there is a PathCR which is significantly improved. Safety profile, definitely safe drug. So this supports perioperative pembro as a new treatment option for patients with resectable lung cancer. That is all the patients who would otherwise qualify for chemotherapy. Then this trial, this drug we don't have, but still this is a similar trial actually. Toripalimab plus platinum-based chemotherapy. Again, EFS is the primary endpoint. And the interim analysis again says that there is an improvement in EFS and across the key subgroups, regardless of the PD-L1 status, squamous or non-squamous status. So these are the two studies on which we will base the neoadjuvant immunotherapy discussion. So I'll come back to Dr. Sanjeev. Do you think that neoadjuvant immunotherapy data is meaningful? Do you think this data is meaningful? You can comment on the nivolumab single agent data and this combination data now.
Yeah, I'm a radiation oncologist. Still, I would like to tell you, if you are adding a neoadjuvant immunotherapy, look at the toxicity part of that. Right. Maybe will it delay the surgery? That's also a question is to be answered.
So no.
Or if there will be a progression, what are you going to do?
There is only financial toxicity. And do you think that
you are putting immunotherapy in a resectable case? So if there is a progressive disease, it will become unresectable.
Okay.
Then what are you going to do?
That is a general comment against all neoadjuvant therapies. It is not specific to immunotherapy. And since Dr. Chiranjan is not there, do you think that if you have more and more neoadjuvant data, like if you start getting PathCRs and all with neoadjuvant therapies, the number of patients needing chemoradiation in the adjuvant setting or in lung cancer itself will come down?
Yeah, if you see, that's what I was telling about both the paper. In one paper, there is no toxicity in 70 gray. Another paper, there is more toxicity in 45 gray.
Right.
So maybe we need to look into how much volume we need to treat. Really, probably it might have, because see, radiation has got a different aspect of response to the immunotherapy also. If you are giving immunotherapy along with some sort of radiation, maybe the microenvironment of the tumor, it is getting changed by the radiation, so that maybe immunotherapy will work in a better way. We never know about it. So probably that is the reason we need to have an optimal dose, optimal volume, then probably we can give, because you have no little bit benefit with neoadjuvant immunotherapy. If you are adding chemotherapy with, you are getting more benefit. Maybe if you are adding radiation with that, probably you might get a better response and better survival also.
Right. So I will come back to Dr. Arvind before I go to the medical oncologist. Dr. Arvind, do you think that more and more neoadjuvant, like combination of chemotherapy with immunotherapy, do you think that more patients will be converted? I mean, that's a term which is usually used in metastatic colon cancer with liver mets, conversion therapy. Do you
Conversion
think
surgery. Yeah.
more patients will go into this?
Yeah, absolutely. I think exciting times, because initially we never used to touch 3B patients.
Right.
And possibly subset of 3C also. I don't know, but 3B for sure. I think there is a scope of conversion surgery in some of them. But I'm particularly excited about the checkmate, this 816 nivolumab data, because there is no adjuvant component to this. Like, and if there is a low dose coming in this way, I think with 3 cycles, with a good path CR and surgery, you're actually done. Like, no, so I think I'm pretty excited. I'm really awaiting the low dose immuno in the checkmate 816 style from the Tatas, actually.
Right. Good. So Dr. Amit, Dr. Arvind wants neoadjuvant immunotherapy to get more patients converted. Do you think that what is your comment as a medical oncologist about the neoadjuvant data? You can talk about the single agent data as well as the combination data.
So surely in the lung cancer, things are changing. And earlier we are treating metastatic. Now the neoadjuvant setting, chemotherapy, giving 5% benefit pre-op, that is fine. But with the coming of the IO in this setting, the percentage of PAT-CR going to 24%, and the, which we say the MPR, that is the major pathological response, is more than 50, something around 50%. So these data are clearly showing that there is a greater benefit with the addition of neoadjuvant, and it is completely changing the outcome of lung cancer. And even I think so the surgeons don't find any difficulty in operating these patients after neoadjuvant chemo immuno. The surgery becomes easier and more patients getting operated and have a good time, I think so.
So you feel that this is a practice changing data, and you hope that in future we will have more patients getting neoadjuvant immunotherapy in lung cancer.
Yeah,
right.
Definitely.
Right. Dr. Saurav, what is your, as a devil's advocate, what is your criticism? Are we jumping the gun here? Are we missing something? Like Dr. Sanjeev said, are we not talking about why there was more toxicity when the dose of radiation was less? What are your critiques of this study?
There are 2 or 3 things. And number one, we are still worried about PAT-CR as a surrogate in breast cancer. So leave aside PAT-CR as a surrogate endpoint in lung cancer. There's
Maybe we don't have that because we never saw PAT-CR in lung cancer.
That is one of the things. But still, we have EFS data. So of course, OS data would be really great to have. So that is something we would look forward to. And the other thing is that some of the patients with stage 3B have also been included in these studies, like we saw in the pembrolizumab. Probably the standard of care would be CTRT in such patients. So the benefit probably is not in the 1B or something. It is more probably going towards 3 and 2 or something in those subset of patients in the higher stages where the neoadjuvant is benefiting. So we need to have some data on that.
So Prasad, last minute.
Last question. So Dr. Jogmaya, we just heard that Dr. Saurav feels that neoadjuvant, he's concerned about the benefit is seen only in the later stages. But as a medical oncologist, are you more comfortable giving a immunotherapy in combination with chemo in the neoadjuvant setting, or concurrent immunotherapy with radiation post-surgery?
I'll be more comfortable in giving a neoadjuvant chemotherapy rather than giving an adjuvant chemotherapy or a concurrent chemoradiotherapy with chemoimmunotherapy with radiotherapy.
Fine. So I think I that's all I have as the discussion points. And
thank you. Thanks a lot.
Thank you, Prasad. Great. So on time also. Thank you. Thank you, Arvind, Sanjeev, Amit, Saurabh, Jugmaya, and Rupanita. So before we move to the debate, so hot debate, so I have the announcement for the prizes for the lung quiz. So first is Shubhangi Singh. And for the second question, there is no correct answer. And third is A. Praveen. Third is Samira Begum. And fifth is Shishpal. So that's the quiz names. So now we move to the AstraZeneca sponsored debate. So adjuvant osimertinib in resected lung cancers. So for the topic of fair, Dr. Nirmal Raut, good old friend from Tata days, practicing in Mumbai. And and this is unfair. So by Sachin Ingemere, again a good friend from Tata, from Pune. So over to you, Dr. Nirmal, and we'll have an expert comment from Somani sir.
So requesting both the speakers to please remain strict to the time period so that we can have the rebuttal and then we can have some more discussion. Thank you. Over to Dr. Nirmal Rao.
Hello. Yeah. Can you hear me?
Yes, Nirmal, we can hear you. Please.
Yeah. Can you see my slides?
Yes, please.
Yeah, okay. So I will be speaking on adjuvant osimertinib in resected non-small cell lung cancer, stage 1B to 3A, mutated EGFR mutations specific population. So EGFR mutations are found in 15 to 40% of the patients. 1 second. Yeah. And we know that EGFR mutations are found in 15 to 14% of patients of non-small cell lung cancer, and they are found in the similar frequency in late stage as well as early stage. And third generation EGFR TKI osimertinib has improved survival compared to first generation TKIs, example geftinib or erlotinib. Yeah. And 1/3 of these patients present with resectable lung cancers, and there is high recurrence rate and poor survival in patients undergoing potentially curative resections for early stage lung cancers. The only adjuvant treatment that has shown benefit in this setting is adjuvant cisplatin-based chemotherapy, which has shown a modest 5% benefit at 5% at 5 years. So there are 3 phase 3 studies of adjuvant EGFR TKIs in resected EGFR mutation positive patients. One is adjuvant, second is evidence, and third is impact, where geftinib and the geftinib and icotinib study was positive for progression-free survival, but it was negative for overall survival. The impact study was also negative for disease-free with their overall survival. So Roy Herbst presented the primary endpoint of disease-free survival in 2020. It was a virtual plenary session, and it showed a starting response of hazard ratio of 0.17 across the primary endpoint, which was stage 2B, 2 to 3A. And across all the subgroups, the hazard ratio was 0.2. So these were patients with completely resected 1B, 2 to 3A lung cancer with EGFR mutations, and they received chemotherapy as per the physician's or the patient's choice. And sorry, 1 second. Yeah. And this disease-free survival was updated in 2022, which showed a long follow-up, and it showed the hazard ratio was maintained. And it also showed that the CNS recurrence was decreased by the use of osimertinib. But did this translate into overall survival benefit? Yes. The answer is a resounding yes. This year at ASCO, there was a plenary session where these data were presented, and the hazard ratio was 0.49 for stage 2 and stage 3A. You can see that the absolute benefit at 5 years was 12%, and the p-value was 0.004. And for stage 1B, 2 to 3A, the hazard ratio was again 0.49, but p-value was more significant, less than 0.001. Absolute benefit of 5 years at 10%. More patients in the placebo arm received EGFR TKIs, such as 88% compared to 76% in the osimertinib group. And this benefit was seen across all the stages 1B, 2, and 3A. The benefit was marked in advanced stages. In 3A, the benefit was more, and in stage 1B, the benefit was less, as you can see in these graphs. And this benefit was seen regardless of chemotherapy, whether chemotherapy was given to these patients or not given to these patients. However, this data does not support the omission of chemotherapy to these patients. It advises giving chemotherapy to these patients. And yes, EGFR exon 19 deletion and L858R these mutations, they have a different survival benefit. The EGFR exon 19 deletion have more survival benefit as compared to L858R, and this is reconfirms the same data as was presented in FLORA overall survival, where first-line osimertinib was compared to geftinib in advanced stages. So in all, these unprecedented overall survival results in early stage lung cancer are practice changing or practice affirming for those who have already changed practice, and dispel the notion of equivalence between early treatment with osimertinib or treatment at recurrence. And they mandate the testing of EGFR mutation in all the patients with early stage non-small lung cancer and treatment with adjuvant osimertinib for resected 1B to 3A disease. These data need global advocacy for access or reimbursement for testing and treatment to avoid worsening disparities and inequities in global access to effective cancer treatment. So this is, in short, the ADORA trial. So the disease-free survival shows, these are the curves which showed that there is an early bulge, which shows that there is a delayed progression, and this is the overall survival where the hazard ratio was 0.49. And the overall survival curves separate and increase the separation over the time. But additional follow-up is necessary to find out these. So,
Nirmal, 30 seconds more.
So this is Sachin Hingmere, my opponent. He has looked this way. So his hair is gray. So I would now like to call upon my opponent to place his side of the debate. Thank you.
So thanks, Dr. Nirmal. So let's invite now the views of the Sachin Hingmere, and I am sure that he will try to dissect out this data, that which may be the patient subgroup which probably are not being benefited, maybe by the stage wise, maybe by the type of the mutation, or maybe that he may reject the data overall. Let's have the views of the Dr. Sachin.
Thank you, Biswas, Dr. Biswas, for this opportunity to be part of this debate and of this wonderful webinar. Nirmal, you have already done a wonderful job, presented data very well. So I'm going to debate as unfair to use osimertinib in adjuvant setting in NSCLC. So before we move on to the data, just revisit our principles of adjuvant therapy. So we are giving a treatment after curative local therapy, and the purpose is obviously to reduce the risk of recurrence, increase the probability of cure, and thereby allow our patients to live longer. But at the same time, we know that every patient after a curative local therapy does not have a risk of recurrence. And then at least a group of patients, when they are given adjuvant therapy, they are at the risk of serious or adverse events. So typically, we have already witnessed with cytotoxic drugs. We believe that a treatment or drugs work better in adjuvant setting. Possibly there's better efficacy when these drugs are used in earlier settings. A benefit that can be achieved when these used are early stages may not be achieved when they're used during the course of the illness. Possibility of cure when these drugs are used in adjuvant setting is more as compared to, or instead of only temporary control when these drugs are used in the metastatic setting, and possibly there's higher effectiveness of these medicines against the microscopic disease. So these are all expectations of an adjuvant therapy, which we have already witnessed with cytotoxic drugs, but we are not sure whether the same principles hold true.
Your slides are not there, no, Sachin?
It's there. I am sharing.
No,
Anita?
Sir, if it's fine, can we share it from our end?
Okay, you can share.
Yeah, thank you, sir.
So next slide, please. Next slide. So this is what I was talking about. So we'll come to EGFR osimertinib in EGFR positive metastatic lung cancer. We all know osimertinib is a wonderful drug, highly effective drug, irreversible third generation EGFR TKI, works better in both sensitizing as well as resistant mutations, has a good CNS activity, and we all know that's a standard of care when we are dealing with patients with advanced or metastatic setting. Next slide, please. And this is impressive data about the disease-free survival, hazard ratio of to the lowest as 0.2. 3 years of osimertinib compared to placebo definitely has shown that the risk of recurrence or the number of recurrences has reduced. Next slide, please. But now let me say that it's unfair from this ADAURA trial that we can conclude osimertinib will fulfill all our expectations of an adjuvant therapy. It's unfair to say that ADAURA trial has been successful to prove that osimertinib works better in adjuvant setting than in metastatic setting. And then obviously it's unfair to say from that ADAURA trial has been successful to prove that patients who received osimertinib in adjuvant setting will live longer than those who would receive osimertinib at the time of recurrence of metastasis. Next slide, please. So obviously to prove that osimertinib works better in earlier setting and would not work the same way when given in metastatic setting, what we needed in ideal trial design. What the trial design should have had, one is osimertinib given the adjuvant setting versus the placebo in the adjuvant setting and osimertinib at the time of recurrence or metastasis. And then obviously overall survival as a primary endpoint would have been definitely a part of an ideal trial design. Next slide, please. But what happened with ADAURA trial? The primary endpoint was disease-free survival. As expected, we are comparing a very active drug against placebo in patients who are having a very high risk of recurrence. So no surprises when we see such a wonderful DFS benefit. But then again, we know that DFS may not be a surrogate marker for overall survival, and ADAURA trial was not powered for assessment of overall survival benefit. Next slide, please. So most critical part of this particular trial is at the time of progression, these patients who had recurrence in the placebo arm, the treatment was left to the patients and physicians as per the local practice. There was no crossover design in this particular trial. So equal opportunity to receive osimertinib at the time of progression was denied in the control arm. So next slide, please. As we can see in this particular graph, the post-treatment details, in the placebo arm, where there were recurrences in 205 patients, there was no treatment in almost 21 patients. EGFR TKI was not even given in 22 patients, and only 79 out of 184 patients received osimertinib. That means only 38% of patients received a standard of care, which is otherwise been considered as a standard of care in all patients who have metastatic disease. So standard of care was denied in almost 38% of patients in the placebo arm. Next slide, please. Whereas if you see on the osimertinib arm, out of 76 patients, 31 patients at the time of recurrence received osimertinib again. So
30 seconds.
No, I'll take some more time because of I'll not have anything from the rebuttal side. Okay. So please allow me. Thank you. So basically 31 patients out of 76 received osimertinib again at the time of progression. So the exposure to osimertinib, a very active drug, is far better in the trial arm as compared to the control arm. Next slide, please. So most unfair, maybe an unethical part of this particular trial is a substandard care which was given in the control arm. Next slide, please. There may be many reasons why this might have happened. Next slide, please. But the most important reason was lack of access or maybe cost constraints. So despite of being a part of a trial, the control placebo arm did not receive osimertinib at the time of recurrence, which was otherwise considered a standard of care. Sponsors, there can be a discussion that sponsors could have provided access to this particular osimertinib in those patients who were on the placebo arm. Next slide, please. Next slide, please. So this has been even recognized by the authors. They have definitely mentioned that the data for those patients who have received osimertinib at the time of progression, whether the survival was same as compared to those who received in the osimertinib as adjuvant setting, the data is not clear, the data is not available, and whether this would have influenced the overall survival, the data is not there. So next slide, please. And again, as we can see, after 3 years of therapy, there's a decline in the curve. So our question is osimertinib preventing recurrence or it is just delaying recurrence? Next slide, please. Apart from this, there were 2 limitations in this particular trial. One was inadequate staging, PET-CT and MRI, which we otherwise considered as standard of procedures, were not done. and no adjuvant therapy was received in almost 40% of patients. So both of these might have added some trial or some biases in the trial participation. Next slide, please. So my final slide,
your extra time is also over.
final slide. So this is unfair from ADURA trial design or trial proceedings to draw a conclusion that osimertinib has improved overall survival. It is unfair to miss an opportunity to demonstrate the real benefit of adjuvant osimertinib if all patients in the placebo arm would have received osimertinib at the time of progression. And then finally, in our practice, it's unfair to expose all patients to financial toxicity of 3 years of osimertinib therapy. And of course, another is 20% of patients had serious adverse events on this particular trial without proving that the same therapy only in those patients who would have recurrence or metastasis, they would have lived the same long term. So it was not proven that it was equally effective. Next slide, please. And then possibly it's I don't know it's fair or unfair. The sponsors for this particular trial as well as for this debate, both are seen. So that's my final take on ADURA trial. Thank you.
Thanks,
sorry for crossing the
Dr. Sachin, for really giving us the insights about the few of the logistics, trial design and other thing which we in the first go we don't feel so. So Dr. Nirmal, you want to say anything in the rebuttal?
Yeah, so he mentioned that 44% of the patients did not received osimertinib only in the placebo arm. The reason was that when this trial was conducted, the patients osimertinib was not FDA approved, and that is why the patients on the placebo arm, when they recurred, they did not get osimertinib because they were not approved by the FDA, and that is why the less number of patients got this drug. Which actually it should have been that ADURA, the sponsors should have given osimertinib to the placebo group also, 100% of the patients, but that did not happen. Only 44% of the patients got the drug because they were FDA approved. That is what I would want to say.
So, anything more comment from both the speakers? No?
No, nothing. I have already taken my time, so I won't.
So if I have to conclude, then the data look quite impressive. And if any trial shows the overall improvement in the survival, leading after the disease-free survival or the event-free survival, then probably we have to accept the trial design, trial data and the outcome of the data without leaving much room or space for the discussion. Yes, always trial design in the view of the new data coming. A new thought process is always debatable, but in select group of the patients, the only question which I want to say to Dr. Sachin is that if the patient cannot afford the osimertinib at the time of the METS recurrence or at the time of the T790M positivity, probably that patient cannot afford in the beginning also. So if the patient can afford in the beginning or in the end, I think it's justifiable to give it in the adjuvant setting. Maybe you can again question that the exon 21 or L858R mutation probably may not be having the difference, but that's again debatable. So as on today, it looks that it's more in favor of the adjuvant. That's my view. Thank you. Thanks to Dr. Ghanshyam and the organizers.
Only final comment, if I may.
Yes, Sachin, welcome.
The real question was, which was not answered in this particular trial, was a patient who has received osimertinib was in the adjuvant setting versus a patient who has received at the time of recurrence. Was there any difference? So that particular question was unfortunately not answered because of the trial design or trial proceedings or whatever reason. So that's what we would have loved to have that particular data.
I can give you for that, irrespective of the financial aspect. Many patients, they are not able to receive even TKI at the time of the progression or relapse because of the poor general condition, or the disease comes in such a florid way that even the drugs, which is so beautiful, patient do not respond. So probably if the disease-free survival leading to the overall survival are showing the impressive results to the tune of the 10%, then I think it's the time that we move to the adjuvant TKI EGFR positive patient with the osimertinib. So that's my message. Thank you
so much. Thank you so much. Yeah, thank you so much. So we have two more talks. So next is sponsored by Roche. Dr. Saurabh Mishra will speak on role of Atijo in a metastatic NSCLC. Over to you, Saurabh.
So can I share my screen, sir?
Please, please, go ahead. Please.
Fine. So is my screen visible to everyone?
Yes, sir. Your screen is visible, sir.
Perfect. So my talk is on the role of atezolizumab in the metastatic non-small cell lung cancer. Mainly we are discussing in the frontline setting. 3 trials we'll be discussing. IMpower 1110 plus 20, 130 plus 20, 150. So these are the 3 trials we'll be discussing. And finally, we'll be having summary and guidelines. One thing is very clear in the metastatic setting, if the patients are not having a target or oncogenic driver, their outcomes are bad unless and until you gave them some form of additional therapy in the form of immunotherapy. There comes, therefore, the role of the atezolizumab. So 3 trials have addressed. 110 tried to ask this question in those patients who are having PD-L1 high, whether you go for single agent atezolizumab versus chemotherapy. 130 tried to address if you are going to do away with steroids, which can impair the activity of immunotherapy, what is the outcome? So they combined carboplatin with nab-paclitaxel, which does not need steroids, combined with carboplatin nab-paclitaxel with any PD-L1 positivity. And finally, the IMpower 150, it tried to show the synergism between atezolizumab and the bevacizumab, that VEGF therapy and immunotherapy. So IMpower 110, this is atezolizumab monotherapy compared with platinum, that is carboplatin or cisplatin, with PEM or GEM, that means squamous or non-squamous in first line non-small cell lung cancer. This is the study design. These patients were PD-L1 positive as measured by the SP142 assay, which shows as tumor cell TC123 or IC123. That is how they say that it is a PD-L1 positive, and they were randomized to either atezolizumab or versus chemotherapy, that is the standard. And you can see here, if you go by the PD-L1 expression, 1/3 PD-L1 high, that is TC3 or IC3, and the other would be the less than TC3 and IC3. So 1/3 will be PD-L1 high. And in the primary endpoint, if you see the overall survival, the median overall survival was improved significantly. The hazard ratio was 0.59 in this subset of patients, which was clinically meaningful by 7.1 months in the TC in this high TC3 subgroup of patients, and it was benefited across all subsets of patients. Now, some of these patients on progression, although this was not a crossover trial, some of the patients on progression had changed to in the chemotherapy arm, had received immunotherapy. So at the longer follow-up, although the graphs were still separating, we can see that confidence interval is crossing 1. But many of the patients, that is 1/3 of the patients, had received immunotherapy at progression after chemotherapy. And when you do some statistical jugglery, you find that again, the hazard ratio is still significant, showing that for TC3 or IC3, the overall survival favors immunotherapy or atezolizumab as a single agent. And next question is, we did the SP142 assay, but many of us, most of us would usually do the 22C3 farm DX assay or the SP263 Ventana platform. These are the much more commonly used platform. What is the outcome of atezolizumab? If at all you measure the PD-L1 through these platforms, you can see very, very similar looking graphs. So whether you have done it through TPS, through 22C3 or through SP263, you'd probably get similar results with improved overall survival with high TPS in such patients. So the conclusion was that atezolizumab therefore represents a promising first-line treatment option in PD-L1 high non-small cell lung cancer. And IMpower is a positive study because there was significant improvement in overall survival, that is TC3 or IC3. Wild type EGFR ALK population, it clearly showed meaningful improvement in PFS, response rates, duration of response versus chemotherapy, and the safety profile was well tolerated. So next we come to the IMpower 150. So 110 was in high PD-L1, that is atezolizumab single agent versus the chemotherapy. Next we come to the combination of atezolizumab plus chemotherapy with bevacizumab. So more and more therapy we are trying to add, because there is a rationale for combination of atezolizumab with bevacizumab. So there is a synergism between their activity, and therefore they have an improved effect, and that is why they were combined. and the randomized study, that is the arm A, and between arm A and the arm B and C. So arm B and C are the more important. So ABCP regimen we call it, atezolizumab plus bevacizumab plus paclitaxel plus carboplatin. This is what was the everything we give compared to carboplatin plus paclitaxel with bevacizumab. And then subsequently we put on maintenance, and this was a subset of patients in the adenocarcinoma subset of patient, not the squamous cell carcinoma of the patients. Now with that, we see that there are patients who are very high risk factors, that is the liver metastasis, which is a poor prognostic factor. They were also included in this, almost 10% of the patients who were EGFR mutation positive. Most of the studies would usually exclude these patients, but here we have 10% of the patients who had EGFR positive. Most of them had actually progressed on prior EGFR therapy. So the primary endpoints, that is the progression-free survival, was statistically improved, that is arm B, ABCP versus bevacizumab and carboplatin paclitaxel. With the addition of atezolizumab, there was a significant improvement in the overall survival, that is 19.5 versus 14.7 months. We need to combine both the agents, because only atezo plus carbo plus paclitaxel doesn't have a different outcome compared to bevacizumab plus paclitaxel and carboplatin. So there was a significant improvement and clinically meaningful improvement in survival, which was also seen in the PD-L1 high subset of patients, and more pronounced there. We do look for the subset analysis. What happened to those patients who were EGFR mutated and they had progressed on EGFR TKIs? There were a couple of patients in these subset of patients, and in this here again we see that there is a clear-cut separation of the Kaplan-Meier survival curves, that is progression-free survival, by the combination of ABCP. So in the EGFR mutated subset of patients who have progressed on prior EGFR TKIs, ABCP leads to, in the second line, the improvement in survival outcomes in PFS. We can see that very clearly. Next, we see the CR response rates. In these subset of patients, there was also significant improvement in the response rate. Patients are symptomatic, so we want good responses, which was also seen with this. Liver metastasis, patients are a high risk, poor subset, poor prognostic patient. What was the outcome? Combination of ABCP versus bevacizumab carboplatin paclitaxel, the hazard ratio 0.41, 60% reduction in the progression. So there was a significant improvement. These are subset analysis. In the liver metastasis arm also, patients have improved outcome. Patients with bulky disease, which were defined as high disease burden, if the size, the longest diameter, the sum of the longest diameter, if it was more than the third quartile, or if the number of sites were more than the median. And again, in this subset of patients also, the ABCP regimen was shown to have an improvement outcome, showing that if patients are symptomatic, we want to go for improved rapid responses, and we want to go for tumor downstaging, then probably this regimen, this combination of regimen would be probably a useful option. And then, of course, when you go for such number of regimens, you land up with higher toxicity. So main take home from the IMpower 150 would be both the co-primary endpoints were met with the combination of chemoimmunotherapy with anti-VEGF. This is the only study which combines a chemoimmunotherapy with anti-VEGF and leads to significant improvement in PFS and OS. And it is also seen in good subset, in the subset analysis, the EGFR mutated subset of patients, the liver metastasis subset of patients, bulky disease patient, they get very good benefit, and we should we may use this in these subset of patients. Finally, we come to the IMpower 130 in again the adenocarcinoma subset of patients, where they went for a steroid-free regimen because steroids may impair the effect of immunotherapy. So here the two arms were atezolizumab plus carbo-nab-paclitaxel with the dose which is given here versus carboplatin-nab-paclitaxel. And in these patients, they were randomized, and the patients, the outcome again, if you see the progression-free survival with the combination of atezolizumab with nab-paclitaxel, there was a significant improvement in the progression-free survival, also in the overall survival. So again, this is a steroid-free regimen which can be used in those patients in whom we want to avoid paclitaxel, and it can be used in adenocarcinoma. All the subsets seem to be benefiting from them, and PFS and OS also we see it here with higher overall response rates also seen in these patients. Toxicity profile is as before. So the key conclusions were from this IMpower 130 is a positive phase 3 study, first-line non-small cell lung cancer, providing an alternative chemoimmunotherapy regimen which is steroid-free, and demonstrated a statistically significant, relevant, clinically relevant OS benefit and PFS benefit also, and across key subgroups it was seen. So all these 3 trials, if you see, it leads to these guidelines. So ESMO guidelines very clearly published in 2023 for the oncogenic, non-onco, without any oncogenic drivers. They say that in the first line, based on the IMpower 110, for squamous cell carcinoma, PD-L1 expression more than equal to 50%, or as was defined as IC more than 10 in this trial, and no driver mutation, atezolizumab is recommended as one of the preferred regimens, recommendation 1A, and MCBS, that is the benefit score of the 5, which is the highest. And for non-squamous, again, in the PD-L1 expression, which is high without driver mutation, atezolizumab is probably preferred as one of the preferable regimens with 1A recommendation MCBS 5. Now, based on the IMpower 130 and 150, where the therapy for patients who are having any PD-L1 expression, that is PD-L1 more than equal to 1%, without any driver mutations, ABCP, atezolizumab, bevacizumab, paclitaxel, carboplatin is recommended as one of the preferred regimen. But here the MCBS score is a bit low, that is 3, which is almost same as the recommendation for pembrolizumab also in this setting. And for non-squamous, it is any, again, for non-squamous, for any PD-L1 expression, it is atezolizumab plus nab-pacli-carbo is also recommended as one of the preferred regimens by the ESMO. So this is all from my end. So atezolizumab has a good role to play in the first-line metastatic non-small cell lung cancer. Thank you.
Thank you, Saurabh, and thank you, Roche, for the sponsorship. So we now move to the day's end talk by Dr. Richa Nathani, a pathologist from Dr. Lal Path Lab. So she will speak on spotlighting non-EGFR mutated NSCLC. Over to you, Dr. Richa.
Thank you for the introduction, sir. Can I share my slides?
Yes, let me try your slides.
Are my slides visible?
Yes, ma'am, your slides are visible.
Okay. So thank you, Dr. Biswas, for this opportunity. I would wrap up this session by spotlighting non-EGFR mutated non-small cell lung cancers. I'm sure much has been covered, but from the lab aspect, I would like to take you. We all know that lung cancer has been divided into small cell and non-small cell. Non-small cell, histologically, we subdivide into adenocarcinomas, squamous cell carcinomas, large cell carcinomas, and others. If we look at the spectrum of the oncogenic drivers that we have in the non-small cell and small cell, there are around 25 to 30, all thanks to the expanded multi-gene panel testing that is being happening today. So how have we evolved and how have we reached this state? It is the initial before 2000, it was small cell versus non-small cell, and the therapies were chemotherapy and radiotherapy. Moving forward, we had squamous versus non-squamous with 2 important EGFR and ALK inhibitors, ALK driver mutations that we found. Now today, when we move across, we have plenty of the mutations, oncogenic drivers that we have found, and also FDA approved drug for each one of them. So this is data of at Lal Path Labs. It is data of 2070 cases over a period of 1 year. This data shows us how are the cases distributed. Barring no pathogenic mutations and EGFR, there lies 28% of the cases. These 28% of the cases are formed out of mutations and translocations. Which are the commonest mutations included in this and translocations? A few of them. The most commonest one, the KRAS, Christine rat sarcoma, sarcoma. It is a member of GTB family located on chromosome 12, short arm. It is responsible for pro-survival signaling. It represents the most commonly mutated gene from RAS family in non-small cell. It is frequently seen in smokers and incidence in non-smoker approaches in around 15%. The mutations in this gene cluster around codon 12, 13, and 61. And they signify a poor prognostic point compared to the patients who are KRAS wild type. The mutations can be substitution, insertion, deletions, and they also have a role in responsiveness of EGFR TKI. Now that is how a normal cell would, after the binding of the ligand, would act. It will shuffle between KRAS, GDP, and GTP and send the downstream signals and go back to its wild type, go back to its inactive state, the KRAS. While when you compare it to the right side, that is the tumor cell, where in the absence of a ligand on the transmembrane, there are continuous signals being sent downstream to the nucleus, and the KRAS is bound to the active form, GTP active form. Like there is a shuffling between the GF-mediated exchange and the hydrolysis. When there is a mutation, there occurs inefficient, the gap-mediated hydrolysis undergoes arrest, and only KRAS activated form stays in. As we know that there are drugs now that have been given in the KRAS G12C mutation, which can be the direct therapies. So KRAS mutant non-small cells these days are targetable, and they can be direct forms, indirect forms, the most common being sotorasib, adagrasib. Coming to the next common mutation, that is the PIK3 mutation, seen in around 1 to 6% of non-small cell and commonly seen in squamous cell carcinomas. Their mutations cluster around exon 9 and exon 20, and they do frequently overlap with EGFR and KRAS mutations. And they have a poor prognostic role when there is EGFR and KRAS wild type seen. Coming to the next common, that is BRAF mutation, the BRAF proto-oncogene, belonging to the same RAS-RAF-MEK-ERK pathway, having a role in the cell division, differentiation, and secretion. There are 3 classes of the BRAF mutation, the class 1, 2, and class 3. The class 1 having commonly BRAF V600E, K, R, M, G. The second one, that is non-V600E, the most common being the G496A and others. While the third one has mutations apart from this. It is seen around 1 to 4% cases of non-small cell cancers, most common being the BRAF V600E, followed by the BRAF class 2 mutation, that is G469A, and less common being class 3 mutations. The targeted therapies that are given are the BRAF and the MEK inhibitors, and the overall survival response rate to these drugs is around 33 to 42%. The ERBB2 mutation, this is nothing but a human epidermal growth factor, also known as HER2, well-utilized biomarker in cancer. There is more of amplification than mutations seen in Asian females and non-smokers. And this clinical response is HER2-directed therapies. Overexpression has shown therapeutic efficacy. Now, apart from the mutations, there are translocations that we see when these samples have been undergone for gene sequencing, for RNA sequencing. The most common ALK mutation that we have seen is that the most common mutations, the translocations that we see, the commonest ones in ALK, followed by MET, ROS, and RET. So the ALK mutation, ALK is nothing but anaplastic lymphoma kinase gene, encoding receptor tyrosine kinase, belonging to insulin receptor family. It undergoes amplification, fusion, mutation, and they've been the driver mutation not only in non-small cell, but also in anaplastic large cell lymphomas, neuroblastomas. ALK translocations have been seen mostly in non-smoker, younger age, and specifically in adenocarcinoma with signet ring cell and acinar morphology. Around 2 to 7% non-small cells have ALK rearrangement. The rearrangement partner can vary from EML ALK to others with their change in the exons. It can be exon 6, 13, 20, 18, 21, and 17. EML4 is also observed in breast and colon, which being the common non-small cell. Amplifications of the genes are seen in some cases, and higher sensitivity to these ALK inhibitors that we have are crizotinib, ceritinib. But there has been a lot of resistance to these inhibitors. It is because of the mutation in the ALK kinase domain. Now, how do these mutations, resistance mutation, function? Most commonly, they have gene alterations in ALK. For crizotinib, alectinib, and seratinib, they have their different locations, or they can be because of the bypass pathway that they are obtained with the amplification like CMET, MEK activation, and c-KIT amplification. Or their pathways can be because of the microenvironment transformation or metastasis. Coming to the next fusion that we come across is the ROS1, a receptor tyrosine kinase, frequently mutated in angiosarcomas, colorectal, cholangiocarcinoma, ovarian, gastric, and non-small cell. The fusion partners vary from CD74, SLC34A2, CCDC6, and FIG. They constitutively activate ROS with all the downstream pathways and drive cellular proliferation. And early preclinical evaluation of ROS1 showed strong sensitivity to crizotinib. It is seen around in 1 to 2% of non-small cells, and they are mutually exclusive with other major driver mutations, rarely concomitant with EGFR and others. They are seen in female, younger patients, never smokers, adenocarcinomas, with the various fusion partners, that is CD74, EZR, TMP3, SDC, and FDA-approved drug was in 2016. Also, it has the most common resistant mutation, that is G2032R. The RET rearrangement. RET is a proto-oncogene responsible for its downstream pathways, various downstream pathways, RAS, RAK, TIC. And the most common fusion partner that we see is KIF5B. And these RET mutations, they have, apart from KIF5B, it has CCDC6, NCOA4, and TRIM33 as the fusion partners with varying exons in KIF5B. And it is also seen in young, never smokers, adenocarcinomas, and advanced stage disease. And the selective RET inhibitor available is selpercatinib. Coming to MET amplification and MET exon 14 skipping. MET, a proto-oncogene on chromosome 7. It is in hepatocyte growth factor ligand factor, resulting into downstream activation of several pathways. MET undergoes overexpression by having mutation, skipping, and translocation. It is seen in around 2 to 11% of non-small cell. And the MET exon 14 skipping is a result of internalization and degradation of the MET receptor, leading to constant activation. It is actionable target, and its signaling is important for cell proliferation, survival, and dysregulated, leads to overexpression, amplification, and mutation. It is also implicated in acquired resistance to EGFR inhibitors in non-small cell, and a number of inhibitors are under clinical development for MET dysregulated tumors. And strategies for MET inhibition include targeting MET kinase signaling, example capmatinib. Summarizing my talk with all the molecular biomarkers directed therapies for advanced and metastatic disease as per the latest NCCN guidelines. And thank you.
Thank you, Dr. Richa, and thank you, Dr. Lal Spatlab, for sponsoring. So we have already come to the last session. So vote of thanks by none other than Dr. Soumya Surat Panda, so who have been instrumental in the success of this meeting. So over to you, Soumya.
Yeah, thank you, Ghansam bhai. Distinguished esteemed dignitaries, on behalf of the International Association of Oncology, it is with great pleasure and gratitude to express our heartfelt thanks for your support and participation in the Oncology Updates webinar held on the 7th and 8th of July 2023. So the webinar revolved around the theme Evolving Paradigm in the Cancer Management, with a special focus on uro-oncology, breast cancer, and lung cancer. So I would like to express my sincere gratitude to the President of IAO, Dr. Ghansam Biswas, for initiating such an insightful and informative webinar series, along with CEO of IAO, Mr. Rudra Manu Satpathy. And I would also like to express my gratitude to Program Director. Dr. Ghansam Biswas has been right there on the forefront, and you can see his efforts for the last 2 days, and that speaks volumes of his leadership in Odisha medical oncology. And we are proud to have such a leader. And besides Dr. Biswas, we would like to thank Dr. Saurabh Misra and also the organizing secretary, Dr. Santosh S. Wagnagar, and the scientific chairpersons, Dr. Tarin Prasad Sahu and Dr. M.B. Chandrakant, for contributing and selecting excellent topics relating to uro-oncology, breast cancer, and lung cancer. And it would be a crime if we don't thank to Dr. Romila Tiwari. She has compared par excellence, such a beautiful comparison we are comparing we have not seen for a long time. And sincere thanks go also to our esteemed speakers for sharing their valuable time and expertise with us during the sessions. So your presentations were insightful, thought-provoking, and immensely valuable to all the attendees. Your contributions have undoubtedly enriched us with their knowledge. I'd like to extend our deepest appreciation to our sponsors, AstraZeneca, Ross, Oncology, Dr. Lalpat Labs, Natco Pharma, Zydus Biosciences, Mankind, Hetero, Biocon, Oncology, and MCure. Your generous support and contribution have played a vital role in making this event successful. And I would also like to express our gratitude to more than 820 registered participants who showed their keen interest in attending the webinar in both the days. So the enthusiasm and dedication to expand your knowledge are truly inspiring. The turnout on the first day was more than 250 attendees, and continued engagement on the second day, again, more than 200 participants, is a testament to the relevance and importance of this webinar. So your comments, interactions, questions have made it more lively. I would like again to express our deepest gratitude to all our sponsors, speakers, participants, and organizing committee and technical team for their unwavering support and dedication. And your collaborative efforts have made this oncology updates a remarkable success. We hope to continue the series with the new research ideas in the future. So with that, thank you everyone. We really enjoyed this meeting a lot. Thank you everyone.
Thank you, Soumya. Thank you so much. And thank you all the back-end support by leading from the front, Sonali, Anita, Sambit, and there are many technical team, and even Siddharth Mahanti and Tushar, so who have been contacting people, the sponsorer. Right. So wonderful journey. So maybe 3 months from now, so we'll come up with, we are planning for a GI and GU and head and neck. So sometime like maybe in October or so. Thank you so much. Till then, stay safe, take care, enjoy your Sunday with family. Till we meet on Monday morning with our patients. Thank you. Good night.
Thank you so much, sir. Good night.
Good night.
Thank you, sir. Thank you so much.
Thank you, sir.